Test 1 2 3. Testing 3 2 1. Test 1 2 3. Test 3 2 1.
Sharon and Karen and the presenters that you all are going to see today. I'm going to give just very basic introductory comments. The purpose of this is to give you guys an idea of some of the things that the major departments do at JPS. And we really broke it down to looking at what we thought really cleared the waterfront from the standpoint of behavioral health to quality to community health um, to all aspects of what we do so that you could listen to this and say, that's very valuable. Okay, I see some of the things that they're doing. So we're going to basically look at some of their initiatives, what their departments are like, overall what they're going to do. And then we're obviously take your question and answers. Each one has prepared a slide deck. Now, you will not see the angst upon their faces, but the angst came last week when the dictum was placed upon them that they could have no more than 3 slides. That was almost like telling them we had to remove a leg or an arm from them because they were like, oh no, I can't do it in 3 slides. But we didn't want you all to get inundated with 67 slides. We wanted to keep this very succinct, but the questions don't need to be. Your questions can be on any realm, and we think these slide packages really give you an idea of a good perspective of what's going on. Then what we're going to do is when we have our second meeting, which will be next week, that portion will be discussing the format for the finance and how we come to the conclusions. What do executive members, department chairs, and managers go through in the finance process that ultimately get to you as a document? And where is that process and what goes through to make that work? So I thought that would be a very helpful situation for you. And I want to thank the chairman for doing this, and I want to thank Chair of the Board Chuck Weber for allowing this. So Steve really has been helpful, and I really appreciate the work that you've put into this with the team. I want to now turn it over to Karen and let Karen make a few comments about the process today. She'll turn it over to Sharon, and then Sharon will head straight to you, Mr. Montgomery.
So thank you, Robert. And I want to thank all of the board members who have taken time this afternoon to listen to the VP presentations. As Robert said, they have spent a tremendous amount of time working throughout the past year, have some great accomplishments that they will share with you. It was difficult to keep them contained, but they were able to do it. And Robert and Sharon and I had opportunity to listen to their presentations, and I learned a lot myself. I also want to thank Robert and Sharon because this is my first year that I am involved in the budget in a different position. And I really want to thank Sharon for really her leadership in leading the conversations across the organization, the initiatives that were spoken about throughout the organization. Sharon really did take the lead on it. And more importantly, I want to thank Robert and Sharon for really walking me through the process, the patience that they showed. I just really want to give them thanks. So I don't want to take much more time. I'm excited, as much excited here in the OPC with my colleagues and VPs that will be presenting, and I want to give them full time to be able to present. So thank you again. Over to Sharon.
Sure.
Hi. So as we walk through these 2 days, today is going to be a lot, as Robert talked about. It's going to be much more introductory. We're going to kind of remind you what all we're doing on a daily basis, where we're going, what we want to do. And then next Friday, we're going to get much more into the changes that you'll be seeing before you approve on August 13th. So it's a very fluid process. I will remind you, someone said you make it look easy. it is a logistical beast to try to get all of these expenses put in. And I hope it does appear very organized and easy for everybody, but we're going to talk a lot about who all has input to the budget and exactly how do we get to the presentation that you guys see on August 13th. So please interrupt me if you have any questions. Some of you are newer to the process than others, but we actually had a couple of changes in the way that we involved people throughout this year's budget for 2021. So you all have the slide deck that was emailed out to you yesterday. Can we go ahead and pull up the presentation?
Steve, do you want to say anything? Steve,
Yeah, would you mind sharing for me a second?
Oh, sure.
Just a couple introductory remarks, and wanted to thank all my colleagues for being here. This was sort of my idea. Well, if it works out well, it's my idea. If it's not, it was Chairman Weber's idea. Robert's idea. So want to touch base. Want to thank everybody for being here. It shows your commitment to what we're doing, what the organization's about, and I certainly am proud to be among you. And thank you to the administration as well. I know a ton of work has gone into this. And we all really appreciate that. Quickly, I wanted to touch base on why we're here. Following last year's budget approval, a few of my colleagues on the board independently reached out to me and expressed some frustration and dissatisfaction with the budget process and our role as a board in that process. Some felt that we were simply a rubber stamp on whatever budget was being proposed by administration, and that we had very little involvement in or understanding of the process of assembling the budget. And I tend to agree with that assessment. So, and that's not an indictment of anyone or any group. I believe it's just simply to be an evolution of the process in general. Taking those concerns to heart, I suggested that this year we try what we're doing here today and next Friday. And I have two goals to share for these workshops, and I hope that you agree. One is for us as a board to listen, learn, and engage in the conversation about the budget process. What are its components? What are its drivers? How are requests evaluated? And what are the many difficult decisions and hard trade-offs that are made throughout the process? And two, as we achieve that first goal, is to, what inputs and feedback can we offer to voice our strategic guidance to the administration? I think we owe that to them as well. What this is not, and I hope that you'll also agree, is this is not a review of the final or proposed budget. We're not taking votes. While the process is pretty far along, there's still a lot of data, a lot of information, a lot of numbers yet to be finalized. That's what we'll do in August. And two, this is not a strategic planning session. I think we do all agree that strategic planning is necessary and that it will happen. And ideally, it probably should have happened before we are in the budget season, but realistically, that's a discussion for next fiscal year, and it's a decision, and timing wise is above my cookie grade. So, and I'll end with this. What does this, my own philosophy? What does a budget represent? And at the very basic level, it represents an operating plan for an organization, whether that be our households, our companies, or $1 billion health network. What are its inputs and outputs? What are the demands and limitations and opportunities? A budget also demonstrates priorities and aspirations of an organization. Where do we want to go? But ultimately, for me, a budget represents the values of an organization. And so as we review this in the coming today and next week and then in August, how I'm going to look at it is, and ask myself, are these proposals or these initiatives or these funding levels, do they reflect and feed into the true, are they true to the mission of the organization? So that's all I'll say. Again, thank you for everybody for being here. I think it's an open discussion. You know, ask questions, engage. I think that's what we're here for. And so thanks. I think turn it back over to you, Sharon.
Before you go, Webb, do you have any comments you'd like to make?
Pardon me?
Before Sharon starts, do you have any comments you'd like to make?
I couldn't hear anybody.
Okay. Chuck, do you have any comments that you would like to make before Sharon starts her presentation?
No, I think Steve covered it very well.
Okay. All right. Sharon, you are, it's all yours.
Okay, so if we can bring up the larger slide deck. The way that, and some of this, I've tried to make this very simplistic, so it will be a little bit more straightforward. But as Steve mentioned, this is $1 billion expense budget. There are close to 350 managers that have involvement, department directors. We have our medical staff, as well as administration. So by the time we get to this point at the board, it's hopefully been organized. And this is a little background about what's done up to this point. We always start to create a baseline budget. So what if things don't change significantly? And how much have things cost us in the past? While we do that, and the one driving force behind our budgets is our volume assumptions. And at the end of this presentation, at the end of my time, we're going to go over a few of our volume assumptions because they're very complex this year with the pandemic and the impacts that it's had in 20 and some of our look forward into 21. But volume assumptions drive all of our patient revenue. We look at historically per unit, whether that's a patient day on a nursing floor, a clinic visit in our outpatient arena, a lab test, but all of those volume assumptions are actually driving what we put into the budget. So our leadership has discussions around volumes first, and then we start to build the revenues. It also impacts our medical supplies, pharmaceuticals, and even some of the non-medical supplies that we have. Our labor costs represent over 50% of our operating expenses. And the majority of the direct patient care areas that I spoke about have the flex with volumes for their labor assumptions. About 56% of our dollars in salaries are what we consider to be fixed FTEs. In other words, they don't flex up and down as patients walk through the door. And about 44% of those are variable. So the actual caregivers are what we would consider to be variable. As volumes go up, we staff up. As volumes go down, we try to staff down as well. The fixed component, that 56%, we look to see who's here and what positions have been approved, and we budget for those at 40 hours a week or whatever their budgeted FTE is. The third big component is our fixed cost. We have to look and see what contracts that JPS is already obligated to. That might be physician contracts for coverage. We have a lot of infrastructure with IT. There's finance, as well as some of the other purchase service that roll through. And then, of course, depreciation. We can project depreciation fairly reasonably, and then we also try to layer on top any additional capital that'll be purchased over the next 16 or 18 months to get an accurate picture of that expense. Next slide. So when we look at revenue, we're going to look at revenue, the top side. We're going to look at the bottom side for expenses. This pie chart kind of shows you where everything is coming from. As you are all aware, our patient service revenue makes up about 39 or 40% of our total dollars coming in. Ad valorem represents just a little bit more than that at 42%. We have supplemental funding at about 10% from our other Medicaid sources. We have retail pharmacy and other as things like grants, tobacco revenue, and anything that is not generated from a patient billing. Now, what is interesting is usually our patient service revenue and the ad valorem tax are closer together. It only looks like about 3%, but that's a lot of money on $1 billion. So what's happening, and we'll talk about this more on day 2, but the patient service revenue has been impacted by the pandemic. And then the ad valorem taxes have been impacted as well. And we'll be talking about that next Friday. Next slide. So from when we look at this, of course, we've already talked about how important volumes are to our revenue. We have to evaluate any changes that are upcoming for managed care contracting or Medicare and Medicaid. Those change annually. We try to get our arms around that. Sometimes it's an increase, sometimes it's a decline. We also have to coordinate with the county on where the appraised values are coming in. We do not get a certified tax roll, which is the basis of how our tax revenue, that 42%, is calculated until the very end of July. So there's still a lot in motion until we can pin that number down. There's also changes that occur annually to supplemental funding. A lot of the waiver revenue, as well as those things that are coming through CMS and HHSC, are not very predictable because of the complex formula funding. Kind of a zero-sum game, so it's not dependent on what we just do, but it's dependent on what the entire state does independently, because everybody gets a pro rata share. So that is incredibly complex this year. There have been a ton of changes to the basis of how some of those distributions are calculated. And then we also have to consider, given another year, inflationary factors in our salaries and our medical supplies and the pharmacy.
Sharon,
Yes.
if I may ask, on the supplemental funding, besides the complexity of it, what's the timing typically of that? How does that factor into our projections?
So a lot of years, we don't have much indication until just before the distributions are actually made in that fiscal year. So during a budget process, we are really guessing. We're using our history, but we try to make the best assumption with the information that we have at the time. That's also on the agenda for next Friday. And we can talk through about where we expect to end up this current year, as well as where we expect 2021 to be.
Because some of those we don't know actually until we're in the fiscal year. Is that correct?
That's correct. So the last few years, what we've tried to do, there are some known changes, like the pool size, for example. If the pool is shrinking by 10%, we can assume our payment's going to be 10% less. Or something called the federal matching percentage can go up or down. And so that would require us to IGT more, or it changes the net receipt, even if you assume everything else stays the same. So typically those 2 items are known, but the rest of it is, unless we have better information, we will just assume that it'll be a like payment for the coming year.
Steve, if you all as board members will recall, not last year, but the previous years, JPS took a approximate $7 million hit and then a $10 million hit after the budget had already passed. And those were, to Sharon's point, it's based on a pro rata share. And the state had allowed, the first year, what they did is they allowed more city-owned ambulance services participate in federal reimbursement dollars. So all of a sudden, the pie didn't get bigger. The amount of people invited to have a slice of the pie got bigger. So we got a $7 million hit we were not expecting. The next year, we got roughly a $10 million hit we were not expecting. So unfortunately, some of that doesn't apply. And also, there are other public hospitals and some government entities that do a fiscal year based on a calendar year. So sometimes powers that be make decisions based on January, not on a September, last day of September budget.
This is DT. May I have a quick question? In terms of the prepay from the insurance or Medicare, is that going to be booked for this year or for next year as a deferred revenue coming in?
So the Medicaid advance funding, I think is what you're asking about. Is that correct?
And some of the payment for Medicare, they average and then prepay, and they will be applied later on when the patient shows up for treatment?
So for most of the receipts that we get early, those sit on our balance sheet until earned. Okay. The biggest portion of that is the unusual portion is the Medicare advance funding for this year. We received just under $50 million for that. And in a few months, Medicare will continue to process our claims, but instead of sending us cash, we'll draw down on that balance in our that we're holding as a payable back to Medicare. So that will take care of itself over the next 12 months. On the payments that we are receiving from Medicare and Medicaid, if they are in advance, and there's always a settlement through our Medicare and Medicaid cost reports, those two items have traditionally, those are liabilities. We adjust and record what we expect to have to reconcile on a monthly basis back to those payers.
Okay. So we may see some different number in terms of cash on hand and all that stuff.
You definitely will. Yeah, if you remember some of the conversations that we've had since March at the finance committee or board level, our cash on hand is incredibly high right now because of some of those concessions for timing that Medicare, Medicaid, and even HHSC on some of the federal funding and the 1115 waiver for DISH and UC, they even accelerated those payments for us. So you will see a natural fall down more to normal level and kind of historical timing on that.
Thank you.
You bet. So when we look at expense projections, again, volume is the key driver. About 32% of our non-labor expense is buried on those volume projections. And then we have contracts that I mentioned that will also be at the contractual rates. After this process is done, and it's kind of a concurrent process, all of those divisional leaders, managers, directors, medical directors, and vice presidents are looking at, okay, what is a new spend? What is it that's not included in this budget that I would like to do next year? Some of those come across as requests for new position. Some capital that we're planning to buy has new operating cost. We also look at new or expanded services for our patients. And then there's items that always come up that are regulatory in nature, and we do have to project those items back out into the next budget year. Next slide. So here's a similar graph for those expense sources. Again, over 50% is salary and benefits of our cost. Again, just as a reminder, about 45% of those are variable. The orange slice of the pie are physician payments. About 40% of those are variable. Those represent claims, professional claims that we pay for our connection patients. And then about 60% of that is fixed through coverage, medical directorships, and other payments. Our purchase service is about 11%. Supplies are about 15%, and the yellow slice of the pie, about 90% of that amount is variable based on volume again. And then we have depreciation and other. Next slide. So with all of those new requests, yes, ma'am. I'm sorry, DT.
No
Thought
problem.
that was Dorothy. I'm sorry.
For the physician payment, can we assume does that include the mid-level provider also as well, or that's just strictly physician and everything else on the salary side?
So the physician extenders are part of those physician payments.
Okay.
There are a few mid-levels that are employees of the medical center, but I would say from a general rule, most of them are coming through our physician contractual relationships, either with a claim or external coverage agreements.
Okay, so most providers are in that bucket then?
Yes.
Okay.
For coverage and medical directors. Evaluation of new requests. We try to do this differently every year. I've been doing medical center, hospital system budgets for longer than I care to count. And every single year has different challenges. You draw based mainly on your ability to change with the times. There's no set way to evaluate these new requests. This year, when we compiled everything that was outside of our baseline, they kind of naturally fell into 5 groups that I'm going to talk about in just a second. In those groups, we appointed at least 2 vice presidents. We also had groups that had medical leaders and directors that were included. We also assigned each one of those 5 groups an analyst from my area to kind of keep them on track and to answer questions if they had a historical or financial question. The groups and the team leads that were appointed to these groups were not given a whole lot of instruction or criteria. And I'll tell you a little bit about the criteria that they developed on their own. And then at the end of the process, the goal was to have these teams rank from 1 to whatever that they felt were important. And they were able to go back and interview the requester of that item. I know that I had to present to one of the groups. So it was a dynamic process. And I think it really opened up a lot of our senior leaders to exactly how difficult it is sometimes to prioritize. We did not have any bad ideas that were on the list. They're all great ideas. And finance typically is the one constricting force behind some of these great ideas. So, we're trying to figure out what can we do this year? What can we do next year? What might be a 1 to a 4 year look? So next slide. These are the 5 work groups, and you can read through the names there, but we had business operations, and that had a lot to do with supply chain and rev cycle, some software optimization, and some capital management. So really kind of a behind the scenes focus in business operations. Care efficiency was a lot around the way that we perform patient care. So we had a lot of Epic optimization that was talked about there, the way that we utilize DME, some pharmacy, as well as, like I said, some nursing and clinical operational type questions. Culture looked at engagement for both physicians and employees or employed physicians. We have all kinds of groups that are here together. And how do we deal with recruitment and retention? The regulatory team looked at a lot of patient safety or risk items. They also looked at required certifications, including the Joint Commission and some of our other more specialized certifications that we maintain. And integrated health outcomes, they really looked at how are we going to do things and how are we changing how we do things. The biggest topic in that one was likely telehealth. We've kind of started to stand it up, but where are we going to go with telehealth and what is that going to cost us, as well as some new treatments or true changes in the way that we treat our patients. Any questions on these 5 work groups? Next slide, please.
On the regulatory, Sharon,
Yes.
I assume that all this stuff flow back to you and Rory also for tracking. What I'm trying to get to is that as we do the PF90, all the stuff with PF3 and all that stuff for the hospital acquired condition, all that stuff, as identified here, you guys also have to refund those back, right? So is there a connection or they float up to you, then we can assume that all that stuff is taken care of behind the scene?
Not all of regulatory would flow up through me or Rory. A lot of it has to do with like the heart certifications that we have in cardiology, the Joint Commission requirements. A lot of what we would have to do, what you were talking about, would actually probably have flown up more through business operations, not just regulatory. And these are not, these were just groups of, we were trying to put new requests in more homogeneous groups and then ask leaders to come in so they could look and evaluate. There was some overlap in some of those groups, but I believe most of the rev cycle would have come up through the business operations group.
Okay.
Next slide. So some of the criteria that was developed by the teams, you know, it would have been difficult for regulatory to use the same criteria as integrated health outcomes or culture. So on the screen there, you can read through those, but there was a lot of great work that came out of there to help assess the importance or the urgency to some of these items. Next slide. So after these teams did their work, each team presented to the senior executives, which included myself, Drs. Hochberg and Duncan. And out of that discussion, all of the people in the room are listening very carefully, but out of that discussion, we came up with kind of 3 groups. There was one group that looked like it really needed to get in, whether it was a regulatory requirement that we were trying to meet. And there were some new things that were actually profitable. There was proposals from rev cycle and supply chain that required some additional salaries or expense, but those were more than offset by additional collections or reduced purchase service expense and spend. So if it was profitable or at no cost, and we deemed it to be at the top of those rankings, we have kind of slotted those into something that would be included in that baseline budget or added to the baseline budget. The remainder of the items went
Sharon, I'm sorry to interrupt you. What does TJC stand for?
The Joint Commission. So, sorry, that's, I tried to take out all of our reference to acronyms, but I missed that one. Some priority items we read and said, yeah, that's high priority. We're either already discussing that at the board level, or it's something that would provide us maybe a year down the road of some real efficiency or effectiveness. And then the remaining requests are already there, ordered for further evaluation. So as we get down to final property tax revenue, we can be very agile as to what can be put into the budget versus what might have to be postponed until later in 2021. So this is my last slide before I get into the statistics that, again, I feel like are incredibly important. Is there any questions so far on that overview? Okay. Next slide. So I've got a lot of volume slides here.
Sharon?
Yes.
I'm sorry. Before you go forward, on the 1, 2, 3, the 5 teams.
Mm-hmm.
What was the determining factor for those persons on those teams?
Well, we tried to pick the busiest people. We also, we're all very busy, but like for care efficiency, we picked Wanda and Diana because of the outpatient, the actual patient care touches. So most of outpatient reports up through Joy. Diana manages the physician component of that. And then Wanda, of course, is over the inpatient area. For culture, Laura Burnside is obviously one of our driving forces on patient satisfaction. Alex over HR would be there to kind of hear from an employee standpoint how those projects might be important. And then Dr. Kramer is, of course, our physician champion. And so those were 2 examples, but we really just tried to make sure that we had vice presidents that not only had purview over some of that area, but, you know, all of the vice presidents were involved. Like I mentioned earlier, I was not one of these leads, but I did have to go present to the business operations group for my supply chain and some of my other areas that I had requests in. And so they asked great questions. It made us look at things very differently.
Okay,
did that answer your question?
Yeah, so yeah, pretty much. The reason I asked the question was because on your previous slide, when we talk about regulatory, I noticed that enterprise risk was not on one of the teams, and that's the reason I asked that. And so I didn't know if his position, you know, needed to be a part of one of those groups.
I'm sorry, which one were you looking at?
Well, I was just thinking about enterprise risk itself.
From Ron's standpoint?
Right, from that position, because you have one of the bullets, implementation risk. So I was just wondering, did that position need to be on one of the teams? That's a question, and not so much the person as more the position, that arena.
That's a great question, and what my response is going to be is some areas and some levels of expertise within our medical center and physician network are pervasive. I think that the compliance and risk is one of those. I think that IT is going to be one of those. And when we start to get these projects more centered, there will be separate reviews, functional reviews of these new requests. Okay. So Ron has been involved in both his risk assessment, but he's also involved in the budget process as well. So we will have kind of a final review of what gets into the budget, and we can follow up with Ron to make sure. But his items were actually already included in the baseline. And anything that we are aware of that is happening from a regulatory or risk standpoint, as that comes up, we try to go ahead and reserve for that in the current year.
Okay. I might be saying it wrong, but I'm not really addressing key position as I'm just looking at those areas down here, perceived risk to the organization, implementation of risk. I just wanted to. My question was, it didn't appear to have anybody on any of those teams that was looking at it from the team perspective coming before them. That's my only question.
Yeah, Sharon, can I add to it, please? So, Reverend Emerson, this is Karen. As far as implementation risk, it was not risk at the compliance and risk level that Sharon was alluding to. It's more around our ability to have the resources to be able to implement initiatives or projects within the next year based upon our state of COVID and a lot of the reallocation of resources that we've had to do. We measured our ability to be able to complete a project over the next year, and that's how she is defining risk.
Okay. All right.
And that risk, actually, that bullet point evaluation criteria came from the regulatory group. And, you know, one of their items they were looking at was a roof assessment. You know, a year ago, 18 months ago, we had some roof damage, and it created some damage to the property. So I think that's how they came up with one of those grading criteria.
Okay.
Hopefully that answered your question. Any other questions before I move into the statistics? Okay. Patient days, this is really a complex slide, but I do want to spend a minute on it, and then I think the next ones will go much quicker. COVID has created havoc on a nice, even, straight line for our volumes, as you all know. And when I started looking at patient days and presenting this slide to you guys, you know, it looked like we were just returning to normal levels. So I'm going to call a normal level the actual fiscal year 19 slide, the second column. The 20 slide is the pandemic year, and that had about a 6-month impact on volumes. And then for 21, there's two ways that you can look at the increase or decrease. The first one is, okay, this year to last year, which is the way we always look at it. If you look at it that way, our change, we're actually increasing days by 10. But if you want to go back to a more normalized year to 19, it's only about a 2% increase. But there's a lot of things that are happening inside of that 2%, as you can see. We included in our patient days are medical surgical, and then we also have ICU and a large component of what we call intermediate care, which is the larger orange slice there in the graph. Because of the pandemic and our COVID positive patients, we've shifted a lot of our medical surgical volumes into an intermediate and ICU setting. So just understand that it looks like a 2% increase from a normalized year, but we're actually increasing intermediate care by 5%. We're increasing our ICU days to almost 50%. And then our medical surgical days are going down by about 10% from a normalized year. So I just wanted to have you have a visual picture. There's a lot of undercurrents behind that total number. Next slide.
Hey, Sharon, actually,
Yes.
I'm a little bit uncomfortable, but with that volume going up like that, you anticipate more JPS connection patient on Medicaid because of the unemployment, or you just thinking we keep everything the same, but the volume will go up?
No, it's more about a slow return to normal. Again, normal, we're not sure what the new normal will be, but we do have to make some type of an assumption around when volumes will return, how we will, when we get into the outpatient setting, how are we going to reopen clinics? Are patients going to come back at the same level? What's going to happen with that telehealth component that we're layering on? Some of the complexities of that are we really don't know exactly how this year is going to end. So we've kind of taken the last few months of volumes and tried to take that on out through September. And then after October and kind of throughout the year, we've ramped back up some of those assumptions that patients will be returning. We have turned on some additional units during the year for the COVID population. And a lot of this information, DT, actually has been built from the bottom up, talking about which units do we expect to be full. You'll see on the next slide here that the ED and urgent care volumes we're expecting to return to normal. But yet we know that from a clinic setting standpoint, from specialty and from primary care, that those are going to have a much slower ramp up.
All right, thank you.
Mm-hmm. Okay, on your screen right now is some of the ED and the urgent care volumes that I just alluded to. We do expect these two to kind of come back up to a 19 level. We're already seeing our emergency department tick up from the March and April impact, as well as urgent care. As you look at maybe a slower ramp up in our primary care, that's where some of these urgent care visits are being projected from. Next slide. On our surgeries, again, this is more of a gradual reopening for surgeries. You can see that our inpatient surgeries drastically dropped from the 19 level to 20. And then the gold bar, which is the 21 budget, has a slight uptick on both of those. And the outpatient surgery volume is still impacted by the Arlington Surgery Center being closed during the elective surgery issues throughout the pandemic. And we expect that to be a slow ramp up as well. The next slide. Invasive labs just had a little dip in 19, and we do expect that they will return to kind of the 19 level. Next slide. For primary care, this is a little bit different view. Rather than just show you the large decline, what I did want to try to capture in these next slides for primary and specialty is the fact that we are layering on top some telehealth. Next Friday, we will go over a little bit more in detail of the telehealth impact alone. But telehealth, we will not be receiving any kind of a payment on the medical center side, but our clinic physicians will be receiving a payment, but that's at a lesser rate of a traditional face-to-face visit. So even though I've tried to include this, I wanted to show you almost the number of touches that we feel like are going to be coming back, and the impact of those visits. So if you look at 19, it's what I continue to call a normal, relatively normal year. During fiscal year 20, we had a tremendous drop for about 6 months. We continue to believe that that's going to be a slow ramp up for fiscal year 21. And part of that ramp up will have people who were accepting the, go back one slide. I think we're on specialty now. Thank you. You're going to see that telehealth visit population actually return more face-to-face. We're doing a good job trying to see all of the patients in the telehealth setting, but as we reopen, there would be things that would be better seen actually face-to-face.
So Sharon, is that just on a payment side that would be better seen as on a face-to-face or actual like?
No.
Okay.
Yeah, no, it has nothing to do with the payments. It's really just, you know, the comfort level of the physician. Right now, we are really not bringing a whole lot of people in to see a doctor, but under normal circumstances, it might be a telehealth visit, but we might want to lay eyes on that patient. Mm-hmm. So that would be more from a medical evaluation standpoint.
Is this also including any of the school-based clinics that we're looking at also?
So yeah, primary care includes all of our outpatient, outlying primary care and women's health, as well as school-based.
Thank you.
Mm-hmm. The next slide is going to be specialty visits, much along the same line. However, specialty visits are not as easily done through telehealth as the primary care. So you don't see the same amount done through the telehealth arena as you would in primary care.
Sharon, can I interrupt you and go back to your primary care just on 1 minute? If the schools are going to delay and possibly 50% of their kids are not going to be returning, they're going to be doing it virtual. How have you anticipated that affecting the school-based clinics?
Well, we didn't, when we're building that, when I said we were kind of building these volume assumptions from the bottom up, we did give the school-based clinics a much slower ramp up. I will also say that this, from a total volume standpoint, the school-based clinics are not a driver of the total volume. We have a lot more volume through women's health and the primary care clinics.
Okay.
But we can break that out a little bit more if you would like to see that.
Yeah, I kind of would like to see that, and
okay.
Maybe your women's health, since that seems like it's going to be your biggest driver.
Okay, I'll make sure we break out primary care into a little bit more.
All right.
Information. You bet. Any other questions before I move into my last slides for psychology and mental health? Okay. Next slide, please. Some of our patient days in psych, they have not seen as large of an impact with COVID. So that looks relatively flat. And the next slide is our PEC, or the emergency clinic. We are expecting to return just about to fiscal year 19 volumes. We did see an uptick there as well.
Hey, Sharon, I just had a question on psych patient days. So psych patient days before, when we were pre-COVID, we were talking about the continual increase from that. And so even though they've states somewhat had a smaller drop this year, And then we're seeing all of the issues of stress and frustration that are happening currently and longer term effects of family on COVID. We're looking at suicide rates with that as well. Do you think that staying the same amount as 2019 with 2021 is sufficient?
Well, for psych inpatient, we typically pretty much operate at capacity. So these are not admissions; these are actually patient days. So we're able to get more patients through. If you looked at a 2 or 3 year trend, our length of stay is going down. We're getting more effective at treating and releasing. So a lot of what we deal with on this slide is capacity. We do have the release valve. That's a purchase service expense for us that, our community partners, once we're full from a mental health bed standpoint, that we can, push them out into another inpatient bed.
Okay, thank you.
You bet. Let's go ahead and skip 2 slides. One back, sorry about that. And this is just our outpatient statistics. As you can see, I've tried to denote telehealth here as well. A big decline. There's a lot of group therapy that happens in an outpatient setting for behavioral health. So you can see that some of those return, but a large percentage is telehealth still for that service. Any questions?
That, Sharon. I'm looking at that on your telehealth. Your numbers will be going down for in this section next year in site clinic visits.
Yeah, the telehealth visits would be down because we would, similar to the conversation around primary care, some of the telehealth visits that we're taking care of now because clinics are actually closed would be able to be moved back into a face-to-face. So, we're just seeing a small decline there from telehealth.
Well, I on that one, I do have a few concerns. I'm kind of back with Amanda. You now have more stress, more increase with the COVID, although we are going up again. They are projecting that we will have more behavior health issues, crisis coming along. So I was just thinking that one, even though you're going to be bringing them in, you're still probably going to be increasing more telehealth because that has been one of the areas that's been very successful in helping with the patients.
Okay, well, we'll go back and I'll get with those leaders and see if we need to adjust anything there.
All right, thank you.
You bet. Any other questions for me before we roll into community health with Joy Parker? Okay, thank you.
Members, what we will have now is we will go through sort of the key areas, and we're going to have each staff member, and the staff member works with obviously their department leaders, their managers, their supervisors, and this is the culmination of that. So the first up we're going to have is Joy Parker. So Joy, if you'll go through your slides and your presentation, that'd be great.
Perfect. And thank you for letting me come back. It's always a pleasure to present and represent all of the great work that is happening out in community health in our division. And so if you can go to the next slide, I'll start off with one of our 2020 accomplishments around the National Committee for Quality Assurance. This is our designation as a patient-centered medical home. And we've had this designation previously, but each year we are required to show evidence and we upload documentation that shows our compliance with over 40 core standards that really are related around what's best practice as far as providing patient-centered care to our patients and their families and our communities. So some of those core components and concepts for those areas that we had to show mastery was around patient-centered access and continuity of care, data collection, medication reconciliation, evidence-based clinical decision support, as well as performance measurements and quality improvement, and very much to our patient experience, as well as our care transitions and care coordination. And so when we talk about budget and we think of leveraging some of the great things that we've done from the previous year, it really truly begins with the outcomes and the measures. And definitely our PCMH and our NCQA really sets a very high standard. So we're really excited about receiving that designation and showing that proof of what we know we are, which is truly striving to be a patient-centered medical home in our community. The next accomplishment that we are excited about is in the end of January, we assumed operational oversight for the Access Resource Center. And so it was a great opportunity for us to, again, continue to build off of the work that had been done to optimize and create a better experience for our patients and as they call in. And so for this year and taking it over in January, just to date, we've been able to rework some phone trees, do some telecom enhancements, and really identify some operational efficiencies and continuity of practice between our clinics and how they communicate with the Access Resource Center and the patients that call in needing our help. And with that, I'm really proud to say we were able to reduce the amount of contract services that are being provided at the Access Resource Center, which resulted in about a savings of $90,000 a month. And so with that, that allows us to, again, use that, that funding to support other initiatives around what we're doing at the Access Resource Center. The
Joy,
other piece in your, yeah.
Hi, this is Amanda. Can you explain the Access Resource Center a little bit more?
Yeah, sure, happy to. So essentially it is a centralized call center service. And so we have our operators there and our team there that really all of the calls that come in to a centralized call center, and we help to direct those calls to the most appropriate place. A majority of those calls that come in are for scheduling. They want to see their physician. And so that activity happens there. We also provide services of our panel care coordinators that actually go through and proactively, like they look at the patient's coming in for the next day to make sure that they're prepared with any diagnostics that they need so that they really have everything ready to go for that appointment. We also have nurse triage there, which we expanded as part of the optimization, and certainly with COVID, we expanded our hours of nurse triage, knowing that more patients, as they were concerned, were going to be calling in and providing live nursing services to handle that and triage that appropriately. So there's a lot of great work that we're doing in the Access Resource Center. We want to continue to build upon that.
Amanda, one other thing, I know you always ask about the language services and the ability to help those who call in with different languages. They are able to connect with our language service and to be able to provide that interpretation.
Great, thank you.
Yeah, and so one of the other great things that we're really proud of is truly looking at all types of different resources for how our patients are.
Joy, I'm sorry. I couldn't get my mic to turn on. This is Roger. You said that we recently took over full operation of the Access Center. What does that mean?
Oh, so my division. So previously it was, yeah. So Laura Burnside's team was doing a great job, but we realized and recognized there was an opportunity to really streamline that continuity between the clinics, for which the majority of the patients are calling into schedule, and bring that operation together. Okay, thank you. Yeah, you're welcome. So you're going to hear us talk a lot about, as we look at budget and what we want to continue to optimize is fully leveraging the technology that we have, and that includes the utilization of MyChart. So in this last year, we worked heavily on creating direct scheduling capabilities. So a patient can truly direct schedule through MyChart. They don't even need to call the call center, but they can make their appointment for a same day or follow-up visit through MyChart. And also some enhancements around Fast Track. And what Fast Track allows is when a patient calls and they cancel last minute their appointment, it sends a message out to some other appointments that have appointments pending in that for that same physician. And it says, hey, would you like to move your appointment up and be seen sooner by your doctor? And so that's been a satisfier for our patients. And we want to continue to build off of that for sure. Our welcome kiosks at our clinic locations, we deployed in multiple PCMH locations this year. And so with that, we are creating a more efficient throughput in our clinics for check-in process. And a lot of the reasoning behind the welcome kiosks is to allow our staff to be able to move back into what we call our pre-registration. And so by doing a full pre-registration before the patient comes in, we know we're going to capture accurate information. We know we're going to make appropriate referrals, maybe to eligibility or other services that they might need in advance of their appointment. So when they come in, they're able to check in at our kiosk that is in English, Spanish, Vietnamese, Chinese. And so it's been, a great feature for our clinics. And again, creating efficiency of practice so that we can then use our resources and our PAR staff to really do some great work behind the scenes to make it a better experience for our patients. The other thing that we're really proud of, Dr. Hochberg talked about is, really when we talk about outcomes, when we talk about why we're here in community health, it really begins with the end in mind of making sure that we help our patients progress to the best health outcomes and really wellness and prevention of disease. And so cancer screening is a big part of that. We partnered with Moncrief and Assured Mobile Mammography to bring care to where the patients are in our community. And we were very proud of the fact that we were able to complete 14,000 mammograms, including our True Worth Clinic place, where we have our persons experiencing homelessness and have seen time over time of early detection so that we can really help to get our patients to treatment quickly. We did the same campaigns around a colorectal and cervical cancer screening because, as you know, in Fort Worth, we have a very high incidence of late stage cancer, and we are definitely trying to do our part to tackle that and to bring care to our patients. The other thing I know Zelia is going to speak to is a little bit about our behavioral health in Fort Worth. And we partner closely with Zelia's team, IT. We get together in a room. We again look at the data. We let the data tell us what we need to know about our populations and how we increase that access. And so this last year, we definitely implemented depression, suicide, and alcohol risk screening for all of our patients when they come for their clinical visits. And it's not just a screening. Once there's positive screens, we actually have workflows that help our patients to get the access they need with our behavioral health team and other support services. Next slide. Oh, back one. So heart health. This is definitely huge. When you look at the community health needs assessment and you see a leading indicator of mortality within our community, it's definitely around cardiovascular disease. And so we knew that when we were trying to do better and provide better care for our patients and their heart health, we need to start with leveraging Epic to include clinical decision support tools that would assist our providers in using evidence-based practice medicine to ensure that our patients are on the right statin therapy to decrease their risk of heart attack and stroke. And so this is a great tool that actually Epic goes in and pulls that diagnostic information and that personal information about that patient, applies a risk scoring to that patient, and then indicates to the physician the appropriate level of statin therapy to reduce that risk. When we talk about heart health, and we know that, JPS, we know we have to partner in order to achieve these goals in our community. And when we sat down to look at heart health and what to do, we knew that the big player that we wanted to speak with is American Heart Association. So we had multiple meetings with the American Heart Association to ask them about their best practices, their programs, and what they're doing at the forefront for heart health. And we partnered with them in using a lot of their great resources and education, all evidence-based. And so we were the first in North Texas to receive the American Heart Association's Target BP Gold status, which basically says 75% of the patient population that we manage has their blood pressure under control. And we know that if we can get blood pressure under control, then we can prevent heart attack and stroke. The other thing that we've done with American Heart Association is the Rise Above Heart Failure program. This is a congestive heart failure program in which we've partnered with our inpatient partners with Wanda's team to identify patients that have come on that have CHF diagnosis. And we support them for outpatient education resources, including a grant that has allowed us to provide scales, blood pressure cuffs, remote monitoring devices that then has our nurse care coordinator calling and checking on those patients. They also are able to utilize an app in which they can enter their weight and all kinds of different statistics that will then flag our nurses so that they can say, hey, it's time for you to come in, or your doctor wants to talk with you, so that we can really make a difference with congestive heart failure in our community. We also have the Check, Change, Control Gold Star for cholesterol management. And again, much like blood pressure control, it says that we are doing a good job of doing our best to managing cholesterol in our patient population. So then we're really tackling that, instance of cardiovascular disease and death in our community. Virtual health, I won't talk long because I know I'm probably going to go over my time, but David's going to speak a lot of the telemedicine and the telehealth that we do. It was very important to us that we provide this access during this time within COVID. When we deployed telehealth for our employee population, we already knew that the success of this, that we wanted to use this to expand in our patient population. And so during this pandemic, we've done that. We ensure that we do pre-screening and get them set up for those calls. We do telephonic and secure video. And with that, if they need translation services, we prepare for that or can do a dial-in at that time to provide translation services as needed during those calls. We provide virtual patient education courses. Again, this is something recently accomplished. So when we talk about educating our patients on chronic disease management, we do that in partnership with a lot of the education of our friends at the Public Health Department. And we deploy that in multiple languages virtually so that we can continue to provide social distancing in a manner in which we can take care of our patients and educate them on areas of disease and prevention. And then the last bullet that I have is around patient experience. It really should be the first, because I will tell you when we look at outcomes related to clinical outcomes, truly the experience of our patients and the services that they provide is at the foremost of what we do when we are making decisions every day about how we implement the care that they receive, as well as when we make financial decisions about how we spend our dollars. And so we're proud of our movement within our outpatient experience questions, and really that related to increases in patients received an appointment when they wanted one, that they had an ease of access in their scheduling, that they felt their provider listened to them, that they felt that the provider knew their medical history. And so a lot of provider guided improvements as well. And so we're very proud of that. And we want to continue to do better. We always want to continue to strive and do better there. Next slide. So key statistics, I had a statistic on my slide about just the growth in Fort Worth. We continue to focus on access, but every year there's about 33,000 new lives in Tarrant County. And so as we think of access, certainly we want to continue that, whether it's, through our Access Resource Center, but also in our telehealth visits and continuing to leverage telehealth and telemonitoring. And I know that David's going to speak some more to that. And I'm going to talk about it on my next slide about kind of where our vision is and where we're going. Obviously, our community needs, when you think about community health, it truly is around those clinical outcomes of how we make a difference as far as those different areas, diabetes and obesity, heart disease and stroke, cancer, behavioral health, navigation to the healthcare system, care coordination, truly meeting the patients where they are, understanding what those needs are, what those drivers are, and then really connecting them with resources in our community, with our partners, as well as within our network. Next slide. So at the heart, you see continue to focus on outcomes. My team is very aware, myself, Dr. Duncan, when we really walked into community health in 2017, we decided we knew we had to measure, and we had to say, this is how almost like when you're sick and you go to the doctor, it's your vital signs. The vital signs of community health are around the clinical outcomes. And so we have a huge focus on measuring that. And some of those other components that I spoke to you about will continue to be at the forefront of how we make business and operational financial decisions for our patients, focusing on wellness and disease prevention, knowing we can't do it all alone, and that we want to collaborate with some of the best partners in our community, that we want to leverage and our data and share data appropriately through care coordination with our providers in the network and external to our network. We know for Zelia's team, and she'll speak to this, behavioral health and substance abuse is an opportunity that we want to continue to leverage with our great work of just identification, but then treatment. And we want to continue to expand access. Optimizing what we have always makes sense to me. We already have it. Let's optimize it. So partnering with David Mendenhall's team in IT to leverage technology to build out my chart, to look at telemonitoring devices. That's definitely a focus for us when you look at what we were focused for our budget. Moving care to the patient home environment. We want to move out to where the patients are. We know we have success there. And so whether that's looking at different community health worker programs, but really meeting the patients where they are in their community and having some understanding, and then being there to bridge and come alongside them as we provide that patient-centered care. And then here you see too, always a goal for us is our eye on the satisfaction and the voice of our patients. You know, I can tell you every leader, we meet together regularly to look at the data, to talk about our action plans. We believe in the plan, do, check, act model. And so when we want to see a different result, then we act on that. I'm very grateful and thankful, Dr. Duncan, Robert, they allow us to dream big dreams. And maybe Sharon doesn't allow us to have all the money to do all those dreams, but sincerely in our heart, everyone that has come together for these budget initiatives has been about how can we make it better for our patients? How can we truly live our mission of transforming the care in this community? And I can tell you at our heart, that is what we're here to do. And I'm so glad I've had a little bit of opportunity to share with you what we're doing. And I'm always happy to answer any questions and love to have the feedback.
Thank you, Joy. This is Steve. That was very inspiring, and I appreciate that much. I will speak for myself, but I'm betting others feel the same way, that we now have a much greater appreciation for the hard work that you guys are doing in community health. Question I have for you, and this is just my assumption in all my years of epidemiology and virology. Question is, thinking about the pandemic in the later stages, and of course we're just looking in a crystal ball right now, but it occurs to me that as we get further along in the process, and hopefully, pray to God that we have a vaccine or therapeutics in the near future, it would seem to me that community health would have a significant role in that, whether it's administering the vaccines or the therapeutics. Have you given much thought to that?
Yeah, certainly. I mean, we talk about that to your point. We're praying that a vaccine becomes available and we are able to move on from this. Certainly I can tell you one of the things our team's looking at is, flu season even is upon us, right? And so we are looking at drive-through flu clinics and developing that. And so from a vaccine perspective, to deliver that vaccine in a safe way, I think that model could be utilized for the same if that vaccine does come about. But you're right, that's part of our role in prevention, is really getting out there. And we're big proponents for that vaccine administration in all of our populations, pediatric to adult and geriatrics.
And Steve, also to add to that, the mobile van that's used out in our community, our homeless community, goes out and gives those flu vaccines. So I know if the board approves some additional vans, we'll be able to go out through all the communities and give all of those vaccines.
Right, Roger and I wanted those vans.
Wow, that's even better.
Yeah, Joel does a great job. Back to Robert's point of I could only have 2 slides, and I had to beg for 2 slides. So really, it would have been on my 3rd slide.
Joy?
Yes, sir.
Can you hear? Joy?
Yeah. Yes, sir.
This is one for Robert as well. And there's sort of been some discussions about this. In my opinion, we should be taking over the public health side of public health. That's just for future consideration.
No,
because what is happening is duplication of services. And I think we should be controlling it instead of public health.
There have been Dr. Weber discussions on a preliminary basis with some county officials. I've also had that conversation in some calls that Amanda and I have had, and I know that's an interest of her input and Steve's as well. I know all of y'all have that. Where I think the discussion seems to be leading is the clinical side of public health may well be better administered by JPS, right, and the regulatory side of public health, such as spraying communities for West Nile, regulating restaurants for safety codes. That seems to be more in the public health realm, and the clinical side seems to be more in ours. I hope they're going to be open to that. We're going to push on that. So before we come to the final budget, there may be some movement in that direction. Good point.
Great, thank you.
You bet.
Hey, Joy, I have a couple of questions. Great presentation. Thank you so much. I know that your team, well, everybody at JPS works so hard, but I know that right now I'm feeling it. I know a lot of people are feeling it. We miss our fairs and festivals to help out the community. And so it is one of the things that we're looking at. I know that with COVID coming through, I love the idea of mobile drive-in immunizations. That's one of the things that we're coming, that we'll see. Are you, one of the questions that I had within the budget, I think maybe Sharon can ask. Sharon, next week, we're actually going to see the budget of community health and what that's looking like. Or Steve?
So we are not going to be bringing like an individual budget for community health. What we're going to be talking about, or what we plan to talk about next week, was more specifically around major changes that might be impacting the budget as it's presented on August 13th.
Okay. 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 Well, with that being said, the other thing that I would love to see, because I know that we're looking at amazing partnerships that we've had with the community itself, is making sure, is there a listing, or if there's some kind of report out that you can have with us on the types of community organizations that are coming through, because we have some great large nonprofits out there that work, but there's also some great smaller nonprofits. I've been working with a couple of different focus groups lately, and from the community itself is saying that they like working with the organizations that have been helping them. However, a lot of those organizations are not the larger organizations, smaller organizations from them. So.
Yeah, I think that's great. We always welcome collaboration and partnership and just understanding of what everyone's doing in the community. So I'm happy to definitely connect on that.
Great. And then my other suggestion, or as we're looking through things, the utilization of my chart, we've seen this across the board. I think it's more of a technology issue than rather an outreach issue, is that looking at the numbers of participants who are in my chart is over 100,000, but then looking at the click rate through is like about 23,000. And I know that people usually don't use my chart until they have a question or something like that comes through. Looking at some type of reporting on my chart utilization would be helpful as well.
Yeah, perfect. And we actually do, to your point, we track that around clicks and who's actually utilizing. One of the great things that we did this last year at Southeast in Arlington was set up much like what Apple does, where we bring in actually some of our patients that use it, as well as with our leaders, and do a demonstration of, as patients would come in and have kind of an education to get them familiar with my chart. Because I think once people actually begin to use it, they realize the usefulness of it, and they're maybe not aware that we've done as many as enhancements for them. And so it's an education piece to that. But yeah, great. Happy to do that.
It's just a great 24-hour utilization technology that I think sometimes, exactly what you said, people don't understand its value until they actually use it, so, or know how to use it.
Right.
Perfect.
Joy, this is Dorothy, and I have a question, and maybe this has been addressed, but one of my concerns is, as you come in and you apply for JPS Connection, and then you are approved for it, there's a disconnect of saying at that point what's available to you, how do you access it, and all of that, and what is the plan to make sure that from, once you approve, how do we get information to them besides you have been approved for JPS Connection? There seems to be a disconnect in that, and what services they have, how they get a primary care doctor and stuff like that. Okay.
Perfect, Dorothy. Yes, and we work closely with Michelle Haynes, and we will continue to build on that, to your point, which is the right thing to do.
I'm assuming this is for JPS connection, is there a plan to roll it out to the managed Medicare and managed Medicaid also as well?
In specific to services?
To the all the program that you have here, the disease, for example, screening and all sort of things.
Oh, yes, sir. Yeah. So we definitely, when you think about these programs, we obviously we do look at our connection population, but those are service offerings for any patient that meets criteria for enrollment into those programs, such as I had discussed.
Because it's also require a potential renegotiation with the plan to include these also as well, because it's falling to Part C, right? And you're going to have to renegotiate them, and then have to have the infrastructure for the RAP score, the star rating, and all that stuff for improvement in coding and all that stuff also as well. Because that when you do that, then you get all the funding that you can get from Sharon.
Yeah.
To speed these up. But other than that, if you still operate on the old model, you throw this in, we're going to be upside down.
That's right. That's great. I tell you, Rory is one of my best friends. And so we talk a lot about revenue cycle and those opportunities, because we know that translates back into dollars that we can reinvest into our community. Great point.
It's a little bit different because right now you're on the model for fee for service. The other one, you actually share the premium dollar that they pay on a monthly basis that we receive. So the total thinking may be different. So, but we can take this one offline. But just if you can develop further down, that would be great for us to transform the whole organization.
Yep, great.
Before we leave from that, this is probably from Sharon to Sharon. Just what DT has mentioned on the contracts. As you do revenue, when you come back the next time, will there be some explanation on which one of those contracts we could look at changing, where we could do more of those programs and get additional dollars?
Yeah, we can look at that. We have had some preliminary discussions with some of the larger payers, and yeah, we can prepare some remarks around that.
Yeah, because you said that the ones that we were active with, that to me would be the ones that you would be looking at to see if we could improve our reimbursement from those. Okay.
Yes, ma'am. Thank you.
All right.
So Joy, thank you very much. You did a great job. If there are no more questions, Joy, I do want to make note of how powerful Joy is. She mentioned not getting money from Sharon, and she mentioned the fact that I restricted her slides. So that's a powerful woman. So Joy, thanks for bringing those up. That's a good idea. So now we're going to move on to behavioral health. And Zelia, if you could go through your slide deck, that would be wonderful. And then you all feel free, as you have, to interrupt if you have any questions, or we'll have questions at the end of Zelia's presentation. So Zelia, it is all yours.
Hey, Robert, I just have one question for Sharon before we move on to behavioral health.
I'm sorry, go ahead.
Sorry, thank you. Hey, Sharon, so when we're for next week, when we look at a little bit more of the numbers itself, will we have high levels of the budget amounts for each one of these fields, for each one of these areas that we're talking about?
So when there's an agenda that has a day 2 on it, so we're going to be talking about certain line items that would be in the final budget. So we're going to be talking about ad valorem taxes. We're going to be talking about some of the more complex supplemental funding changes that we're going to need to project out. We're going to be talking about pervasive changes like the telehealth. We don't have a budget to show you in a week. There's still a lot of moving components to that.
Yeah, just to interrupt here, I think that's, Amanda, our plan for the 13th of August is we actually get the hard numbers to make decisions on. Is that correct, Sharon?
Right. It will be I think everybody that's on the board now was here during the last presentation. So
Yeah.
I'm just trying to identify items next Friday that are more than just an easy discussion, similar to what we had last year. So on the 13th, I can say, now we've talked about this and here's how it rolled into our final number.
Okay, perfect. I'm just getting kind of framework for it. So I appreciate that. I know it's a lot of work in a short period of time. So thank you.
There is.
And Amanda, we don't want to disappoint you or create expectations from anybody of a level of frustration. What we'd hope to do is give you all ideas of what is taking place in the key components that drive the whole health network and the care that our patients receive. Then next week, we wanted to really talk with you, even before we do the final budget, we wanted to talk with you the externals that can affect everybody's budget, such as federal reimbursement dollars. So as far as next week, I don't want y'all to think next week we're going to have a detailed budget to go through, because we wouldn't, not only would we not be at that, but we want to help you all get to the point of understanding how we even go through that process. We're not even there yet. So I don't want to disappoint you at all. And I know that's not what you're asking, but I want to make sure that our expectations are giving you the information right now that you need for your August 13th meeting, where you do go through the particulars of those, the budget in its details.
Right. Great. Thank you. Thank you. I appreciate it.
Are there any other questions that y'all may have of Joy in her presentation? Okay. Joy, thank you very much. I certainly appreciate it. And I really appreciate your managers and your supervisors helping you put that all together. That's very helpful. Zelia, now it is all you.
It's an honor to be here. Jeffrey, can you move to the next slide? I appreciate this opportunity to share some of the great things that the team in behavioral health have been doing this fiscal year. And so I kind of wanted to review some highlights for you. And of course, if you have questions, I'm certainly hope I have the answer, or if not, I can find it for you. I think it would be remiss of me to not list the first accomplishment of us being one of the first in the nation to open an inpatient psychiatric COVID positive unit. That was a challenge that arose from an emergency, and as a result of that, we opened this unit in 3 days. And it was a 14-bed unit. And one of the things that speaks to the spirit and heart of the nurses and employees in behavioral health and here at JPS, we had staff volunteer to be on this unit. We did not have to ask anybody to work a shift on this unit. All the staff did. And so it was open for about 8 weeks, and then we were able to stand it back down. But that's something that we're extremely proud of, that we were able to do during this pandemic. The second area that's been a great opportunity for us is decreasing our average length of stay in the psych emergency room by 2.7 hours year to date compared to where we were this same time in fiscal year 19. And there's 2 main reasons why we've been able to reduce the length of stay in the PEC, which has definitely improved the patient experience in the PEC. First of all, on average, almost 50% of all of our discharges occur before 10 a.m. in behavioral health. And so this frees up the beds earlier in the morning so that the EVS team is able to clean the beds quickly, and we are able to move patients quickly and sooner out of the PEC to these beds. Another big area for success for us has been weekend discharges. We didn't really do a lot of weekend discharges before, and so we met with our physician partners, and set some metrics for weekend discharges. And this fiscal year, we're averaging about 35 weekend discharges a month, which helps decompress the psych emergency center on the weekends significantly compared to 18 a month in fiscal year FY19. And so it's been almost a 50% improvement year over year. And that really could not have been accomplished without our physicians and their partnership. Joy mentioned in her conversation about our district measures and the partnership we have with community health. And so with community health, we have assisted them with training and getting all their things in Epic for them to do screenings for suicide risk assessments for child and adolescent, as well as adults, but not just, and for substance use, but not just the screen, but also referral to us for treatment. And we have people on call that if it's a high suicide risk score, whether it's an adolescent or adult, that we're paged and respond within 30 minutes to that primary care clinic provider and treatment team. But this fiscal year, we're at 88.4% of all child adolescents coming to primary care clinics being screened for suicide risk assessments, which is amazing. And for adults, we're at 89.52%, which is a 32% improvement over target from last year. And next slide, Jeffrey. And some other accomplishments that we've had this fiscal year regarding behavioral health quality core measures. Our seclusion and restraint numbers, year-to-date scores, we are surpassing the national average. And then when you look at, we do tobacco use and substance abuse screening measures and referral for treatment on every patient admitted to JPS and behavioral health. And we are above the JPS benchmark and national average in both of those areas, which really speaks volume to our staff's commitment to try to get patients the treatment that they need. Another big area of opportunity this year has been, we have significantly reduced overtime FTEs for behavioral health inpatient units. In FY19, we were running at 8.4%, and this year we've dropped to 3.2%. And so that's a significant savings monthly that is able to be redirected elsewhere in the district where those dollars are needed. And so that's something that we're proud of. Next slide. I think when we're talking about behavioral health, we've got to look at what's happening in Tarrant County, what's happening nationally, and the impact of COVID on mental health. And the first thing I'd like to review is just key statistics for you. 2018 is the most recent data for the suicide rate here in Tarrant County. And Tarrant County continues to see our suicide rate increase significantly. And when you compare our suicide rate to Denton and Collin and Dallas County, you can see we're the red dotted line, well above everybody else. We're at 14.2%, which is a significant increase. That's 14.2 people per 100,000 covered lives that kill themselves in Tarrant County. You may ask, why is Tarrant County that much higher? I think a big part of why is the method of lethality that's chosen to commit suicide. In Tarrant County compared to other counties, guns are the primary choice of weapon, as well as by hanging. And those two events or methods of lethality are difficult to recover from versus an overdose or another method. But we do have a suicide problem in Tarrant County, and it certainly is going to be exacerbated by the impact of COVID-19. When you look at what's happening nationally, 11 people die each day by suicide. There's 4,000 deaths a year by suicide. 1 out of 3 deaths by suicide are among people 45 to 59 years old. and it's the second leading cause of death amongst youth aged 15 to 34. Suicide rates are approximately 3 times higher amongst men compared to women. And again, that is related to the method of lethality. Men oftentimes choose guns, whereas women oftentimes choose prescription drugs to commit suicide or with their attempts. And when we're looking at the impact of COVID-19 and what it's going to do here in Tarrant County and to JPS, when you look at COVID-related increases in deaths, they're projected to start as the pandemic drags on, which unfortunately it is. And unemployment, isolation, social support issues, cultural divisiveness become more and more pronounced. And sadly, we're seeing all of those things at this point. These deaths are anticipated to be both suicide and substance-related deaths, and they're usually referred to as deaths of despair. The Meadows Mental Health Policy Institute has projected that in Texas, without an increase in preparedness to detect and treat depression and addiction, for every 5 percentage point increase in unemployment during the COVID recession over the year, we'll have an additional 725 Texans that could die from suicide or drug overdose. And certainly, unfortunately, everything that has been identified from the pandemic dragging on and unemployment and social isolation, we're experiencing all of those things as we speak. Next slide. When we look at what is a vision for the future for behavioral health, again, it's continuing to optimize on access and throughput, continuing to promote provider and staff engagement, development, and satisfaction. That's been a huge focus of ours this year to help with provider and employee retention. And so our providers are in all of our visioning sessions, our partnerships for planning and goals and anything that we are developing. And that's been a huge part of our success. Again, we want to continue improving the quality of care we deliver because that's what makes us better. And of course, we have a bunch of type A's over there in behavioral health, and we like being number one. So that's our goal. We also want to create financial sustainability and develop and maintain strategic community partnerships, such as the ones we have with MHMR or the Fort Worth ISD, the Arlington ISD. There's a variety of partnerships that we have across the community with behavioral health that we're able to have a far reach. And with that, I'm going to end my presentation and ask if you all have any questions.
Thank you, Zelia. This is Steve. I don't really have a question, but I definitely appreciate this, and I know that, and I appreciate your, planning and being prepared for the other side of the pandemic, so to speak. The other side of the economic shutdown that we all need to be cognizant of, and so I really appreciate your thoughts on that. Thank you for that.
Zelia, this is DT.
Yeah.
It's for just a question around the core measure, hospital-based inpatient psychiatric service core measure. There are 7 of them, and we're doing the 2 and 3. Is there plan to do the 1, 4, 5, and 6, 7? Around?
We do. We're doing all of those. I just picked those 2 to present. But yes, sir, we're above national average in all of our quality core measures.
Okay, so for all 7 of them, the screening with the
yes, sir,
antipsychotic medication, all that stuff.
Yes, the antipsychotic medication, the tobacco cessation, substance use.
So that will be the continuity of care planning happening also as well.
Absolutely correct.
Perfect. Thank you.
Yes. Sure.
To Amanda's point earlier and to Dorothy's point, one of the challenges that we will have and you all will have as board members is trying to look at the impact of unemployment. And unemployment is going to come in two categories: an increased amount in our connection population and those needing our services. And then to Zelia's area in particular, when you see an increase, unfortunately, of spousal abuse, child abuse, and suicides, it all becomes very, very impactful to JPS. So we're going to have to do our best to figure out what that impact can be. On the unemployment side, there are actually trends that are easier to follow. On the suicide rates and spousal abuse, partner abuse, and child abuse are much more difficult. So hats off to Zelia and her team, and hats off to Zelia in her efforts to create the behavioral health COVID unit. They acted exceptionally quickly. And so when Roger Fisher calls and says, hey, what can we do, or how can we as board members help, it's understanding these situations, because Zelia's got about 8 hours to turn things around. And so that's where you have an operations aspect and a board's guidance through its direction for people like Zelia. And it's hugely helpful for us to know your direction, but it's also helpful for Zelia to use that 8-hour turnaround time to do what she has to do immediately. So hats off to you and your team, Zelia. I know that it is weary on your team, both emotionally and actually physically, because the other thing that Zelia did not say is, although we have reduced restraints significantly under Zelia's leadership, we are finding, unfortunately, an ever-increasing violent population in behavioral health because of their higher levels of frustration and almost, there's nothing left kind of approach. So congratulations, Zelia. Any questions y'all have of Zelia?
This is Dorothy, and I don't have a question. I just want to say hats off and thanks to Zelia that I've had some, had to call and give some, make some referrals to the behavior health. And everyone has come back and said, what a wonderful job and a quick response. So I just want to say thank you, Zelia, for your help. Okay. And great presentation.
Thank you, Ms. Dorothy.
Hey, Zelia. Yes, I just want to reiterate, because y'all been doing a fantastic job, and I myself have done the same thing, and y'all have been fantastically amazing. I just had one question about the percentage that we're seeing with adults versus adolescents, and what that partnership before looked like when we're moving through. Y'all been doing an amazing job of being able to filter into group therapy, to be able to utilize that. And what are we looking at between adults versus adolescents?
With regards to have been impacted by COVID-19 or positivity? Right. The positivity rate has been actually higher for adolescents. We did reopen our adolescent unit. It's almost full now. We're testing adolescents prior to them coming to Trinity Springs, just like we are adults. And the first 2 adolescents we wanted to send for admission last week, both of them were positive. And so we've actually had a higher positivity rate. And of course, they're not symptomatic at all. But with adults, we are seeing an increase in the positivity rate. We may be at a point where we have to reopen we're calling it a wing now. We're not going to close down the adolescent unit this next time. Hindsight's 2020. And so we figured out a way we can open up like 6 rooms on a hall of an adult unit, and it be blocked off, but able to be safe, so we can keep the adolescent unit open, because that's just as important as well. If we see, if the hospital census becomes, our trigger point to pull that off is if the hospital census becomes 5 or greater of psych COVID positive patients, then we would need to open up that wing.
Thank you.
Thank you. Any other questions? Well, again, I just want to thank the board for the opportunity to present, and thank you all for your support. Time.
David, I hope that you can hear me because my system just said it is shutting down for some reason. So the next person up is David. And David, if you could go through your slide deck, that would be great.
Great. Yeah, I can hear you, Robert. Thank you very much. Thank you, members of this board. Jeffrey, if you'll go ahead and go to the next slide. And let me go through the 2020 accomplishments that we've had from an IT perspective. The first one that the first two actually I want to mention are projects that we did not have on our calendar or on our slate for this year. They were projects that were thrown really in together as part of COVID. And our telehealth phase one, we were doing some telehealth. Let's be clear, from psychiatric patients and some physician to physician things, but really going from community health to a patient was not something we had on our radar screen for 2020. And we, with our partnerships with Joy and her team, and our partnerships with Dr. Henderson, who's our Chief Medical Information Officer, and Dr. Lau and Dr. Saad, and all of these wonderful community health providers that are out there, we were able to put together a telehealth program that now we know what we know, and we know some of the things that we didn't know, or we could put together a plan for future years moving forward. Now, obviously, there's a financial impact to that we're still studying, that Sharon and her team are studying what the revenue issues are going to be with telehealth moving forward. So we're not going to be, sprinting out and saying, 100% of our community health visits moving forward are going to be telehealth, because that would be financially very detrimental to the hospital network or to the health network. So as they're studying that, as Sharon and her team are studying that, those are things that we're going to be putting in place for future years. The mobile and remote workforce is another accomplishment that we had. We had back in January doing a study, we probably had about 200 to 250 people throughout the organization that were able to work remotely if they needed to. And we had physicians that were able to use Citrix to be able to look at charts. But when we went into COVID, we went from 250 down or up to about 1,500 mobile employees and physicians within about a 2-week period. And that was a really huge accomplishment from our team, and very proud of that. One of the other accomplishments that I want to bring to you guys' attention was the streamlined data extraction process, supporting analytics and Power BI. And why that is important is over the last year and a half, we've been working at trying to get out of this constant build a report because somebody needs a report, and getting more to a situation of somebody knows where that data already is. It's on an Epic screen somewhere. It's on a Radar dashboard screen somewhere. And let's look at the data where it exists, work with that person, and then extract it to then be able to put it on into Power BI or some other other analytic platform. Why that's important is during this COVID process, we were able to put up a dashboard that I don't even know how many data elements it has now. It's hundreds and maybe even thousands of data elements from Epic, from our supply chain, from all the things that are happening through human resources, and be able to put it so that the leadership of this hospital was able to analyze that data on an hour-to-hour basis, sometimes a minute-by-minute basis of what's happening, on how many COVID positive patients we have in each unit. And if we would not have taken that approach about a year ago, we would not have been able to do what we did during this COVID crisis to get the data and information in front of people as soon as possible. So I'm really proud of that. We've also moved to semi-annual and quarterly Epic releases. That was a big push this last year as well, because we were doing releases with Epic about once every 18 months. And now we've moved to major releases being done, sometimes quarterly, at the very minimum, it's semi-annually. We brought a new data center online. We've enhanced our cybersecurity program. And we also integrated the biomed clinical engineering team underneath IT. So when we look at the Internet of Things, when we look at smart beds, when we look at IV poles that are emitting data back and forth to Epic, it was very important to bring that group underneath IT so that we could have some streamlined processes and have some consistent technological standards across the organization. Jeff,
David,
next slide.
David,
Yes, go ahead, Dr. Holder.
What is an epic release? What happens?
So let's call it an epic upgrade, right? So we were doing epic upgrades about every 18 to 24 months. And because that's really how long it took to work through a lot of the issues that were there. And we kind of put our development on its ear and changed it within the last year to more of an agile methodology. And so when we did that, we were able to then start taking these massive epic releases that come down from epic every 3 to 6 months, and as opposed to waiting sometimes 2 years. For instance, we have some things that we have to do at the end of this year that are all about the Cures Act, right? And promoting interoperability. That's a regulation that we have to be able to do. In previous, and things within Epic that have to be able to prove that we're doing that properly. In previous methodologies, what we would do is we would start on the build of that 2 years ago, hoping we would hit the mark at the time something from a regulatory perspective was due. Now, the methodology that we have now, we can do that within 3 months. When a new regulation comes out, within, let's say it comes out and some things came out earlier this year, we can then guarantee we can get that done by the end of that calendar year.
Okay, great.
Great question. I know this particular screen is an eye test, and I don't mean it to be, but this is some projections that were happening at the end of 2019 about what some very smart people thought was going to happen within 2020. And I'm not going to go through every one of these. I'm only going to go through a couple of them that we have really sunk our teeth into and realize it's having an impact here at JPS. The number one is the rate of change and transformation within IT. Many of you guys know my resume. I've done a lot of other things and been in other industries other than just in healthcare. And in healthcare, our rate of transformation within technology is really kind of the slowest. I've been in financial services, I've been on the retail side, and in healthcare and oil and gas. And retail always wants to be in front of things. Financial services always wants to be in front of things. It seems like we're always lagging. And the projection was that the rate of transformation within IT, within healthcare, was going to increase. And boy, have we seen that. COVID threw us in the middle of that increase this last year. And the rate of change that we're doing now versus what we were doing a year ago is not a multiplier. I think it's an exponential rate of change. And we're seeing that throughout the entire industry. Numbers 3 and 4 talk about telehealth and what the adoption rate was going to be. And we've seen our patient base that a year ago, if you would have asked me if we thought our patient base would adopt telehealth services, I would say it was a 50-50 chance if many of our patients would adopt it. And we're seeing that 75-80% now that they're willing to do telehealth. So that was a major transformation. The last one that I want to talk to, and I'll get to how this works for us in the future, is number 9. And it talks about the engagement staffing models that we're having to work in. This is really hitting close to home right now because it's talking about the gig economy. And the gig economy is relatable to someone that'll take a job just to get that next $15 or that next $100 or the next $1,000. And then they're off to their next gig to get their next $100 or next $1,000. If you've used ride sharing programs like Uber or Lyft and you've used those, you'll notice if you watch your driver, the driver has probably 4 or 5 services that person is taking requests from at that time. They're looking at their Uber queue, they're looking at their Lyft queue, they're looking at their Grubhub queue, they're looking at their Uber Eats queue, they're looking at their Postmates queue, they're looking at all of those queues constantly, so that they know once they drop you off, what the next service that they're going to provide to get that next gig, to get that next $20 or whatever it is. And that did not stop. That is now happening in the IT world as well. We had a particular employee that we had hired here. He was a shining star. We hired him as a desktop technician, and within 3 or 4 years, he had doubled his amount of income that he had been making at JPS in that amount of time. And he was on a track that was incredible. But that wasn't enough for him. He was a young man at 24. He decided to go and leave JPS and move into another role. But what was really interesting is he took another full-time job, and within 3 months, he was not only working that full-time job, he was also working for a consulting company, and that consulting company then wanted to use him on one of our contracts so that he can come and do work for us. He had a full-time job, but then they wanted to have him come and work for us on off hours. It's that gig economy. And we have to be very cognizant of that as we're moving in, because the projections are that 50% of the gig economy right now are millennials. And when we look at our staffing, that over 50% of our staffing is millennials, we need to be cognizant of that. And when we're looking at doing staffing engagements and building our staffing models, particularly in the tech field, we've got to be ready to handle that and move through and get value out of people as much as we possibly can. So that's one of the things that's hitting us. Jeffrey, next slide. Some of the things that was on the previous slide that is on this first bullet point is our vision for the future is, number one, obviously embracing tech future with artificial intelligence, machine learning, and robotic process automation. And how is that hitting JPS? Well, I've always been very reticent of using terms like artificial intelligence and machine learning because, quite frankly, I don't think that those really do exist. I think that being a career technologist, it's somebody's intelligence to begin with. And it's usually a person that writes a script and just kind of keeps on going through. And machines that are learning are really more about taking data and then putting them into areas so that then we can use that data to build predictive forecasting. There is some things, though, that are coming out that we're looking at right now. In fact, we're getting ready to go pilot phase that I think really embraces both AI and machine learning. And we're doing that with a company, with our 3M 360 product group, that is allowing us to, hopefully within the next month, we'll have this in pilot phase, that will be reading a chart real time. And as it's reading a chart when a physician is documenting in that chart, it is then looking on the backside to see what coding could be done for that physician and giving that physician real feedback while they're documenting in that chart. That is a really big efficiency for us at JPS. It's really going to be a big efficiency for, I think, the entire healthcare spectrum, because right now, if a physician miscodes a chart, they are then to their next patient, and they don't get feedback for about 48 hours from our coding department of whether or not there was something wrong with the way they coded that chart. So we go back in, and then they have to come back in and try to get into, after they've seen another 100 patients, remember where they were with that patient to be able to then change that chart. So if we can give them feedback while they're coding, I think that's going to be a huge, huge efficiency for physicians. One of the other things about robotic process automation, that's another new technology that I'm going to kind of show my age a little bit. If you remember macros in Excel and macros in Lotus 1, 2, 3 that we would build, that's what RPA is. It's a macro-based system that you can go in and say, in script, here's an automated or here's a repetitive thing that a person does. And we can then record that in the background so that they hit a button and the machine will automatically do what that person was planning on doing. That's one of the things that we're keeping our eye on right now. And in fact, we have our first case study here at JPS that we're going to want to implement that within the next 6 to 12 months on the revenue cycle things for insurance eligibility. And we're really excited about those types of technologies. So our eyes on those future tech are some of the things that we're doing. One of the other things we're always keeping an eye on is balancing data accessibility versus data security. And that is always a tough one because more and more data needs to be out there all the time. And Jeffrey, if you can go back a slide, I want to look at one of the other statistics that's there. And it's number 7. And number 7 talks about 25,000 petabytes of data that would be available for research. Now, that 25,000 petabytes is a number that nobody understands, but let me put this into perspective. A petabyte is the equivalent of 220,000 DVDs. So if you can imagine all the DVDs that someone may have with movies or data and so on and so forth, imagine a room that has 220,000 of those DVDs full of data. That's what we're talking about when we talk about a petabyte. So if you can imagine a room with 220,000 DVDs in it. Now imagine 25,000 of those rooms. That's the predictor of the amount of data that's available for research. Now, Jeffrey, go to the next slide. So when we look at data accessibility and data security, there's a lot of things that we can be involved in that could be very beneficial for our patients. We always have to be watching the clinical research aspects of what we can be doing, but we have to balance that with data security, and we have a team that's doing that now. One of the other things we're looking at for Vision for the Future is obviously increased mobility for caregivers. Right now, we have lots of tech that a caregiver has to have, whether it's an ASCOM phone, a cell phone, a pager, a tablet, a laptop, barcode scanners, and a lot of those other things. And we're looking at doing a bunch of consolidation around that and making it easier for caregivers to get around the organization, get around through our inpatient side. And then also more technology for our patients. Joy kind of talked about that a little bit with what we're doing with MyChart and changing that around, doing telehealth through that, whether it's remote patient monitoring, more kiosks, and more, maybe potentially more kiosks in non-traditional areas, right? So eventually, instead of just doing a kiosk, we might do a kiosk at a community health center, but then maybe eventually doing a kiosk at a grocery store or at a library or somewhere else or at a school, and looking at those ways to have access to our patients and giving them more tech than what they have available to them today. Then we're always streamlining back-end processes, and that's because of the next one of expanding enterprise systems and decreasing niche systems that are out there. Our eye obviously is on consolidation of the over 300 applications and the 70 projects that we do every day or every year. And those are sometimes get a little bit daunting when we look at those numbers and trying to keep all of our stakeholders happy and keep all of our stakeholders moving forward. Because as you've heard from Zilia and from Joy, their markers change every year. And you're going to hear that from Dr. Elliott, from Dr. Stevenson. These markers change every year. We've got to be able to consolidate some of our systems down so we can have better support of the ones that we can take hold of. And finally, building a more dynamic workforce. We're in the middle of doing, or we're going to be doing a skills gap analysis for the tech that we know we're going to need over the next 12 to 24 months, and building that into our normal staffing so we can build a workforce that's ready, not just for the things we do today, but like COVID, that advanced our technology stack more rapidly than we had ever imagined. Now we got to build a workforce that can get us to that next level as well. So those are my updates. So does anybody have any questions about all of that?
I want to, you've heard the name Jeffrey called out a couple of times. We have a huge amount of people that allow JPS to operate properly. Jeff Wright is one of them. Jeff is behind the control room. And I want y'all just to think for a second of the undue pressure on this poor man. He is actually running his boss's slideshow. If he pushes the wrong button when David says, Jeffrey, next slide, that's immense pressure. So to Jeff and the other 6,000 people that are in that organization, they're amazing. And we're thankful and gifted to have people like Jeffrey Wright.
Absolutely. Absolutely.
Thank you, Jeff. And thank you, David. I know you're a tyrant. If someone pushes the wrong button, heads will roll. Thank you for that very great overview, though. I'm really excited about your vision for the future.
Great. Thanks, Steve. I appreciate that.
Yeah, and we had a great call about telehealth, and kind of one more thing about the take-home packets right now, and case manager packets of oxygenation and what they're looking at and monitoring. So it's really a forefront kind of response right now. So really appreciate that from you and your team.
You bet. Thank you, Amanda. Appreciate that.
The office that Jeff is in also, Derek, is really critical to me, because there are times during my day in my office, there are two buttons on the side of my computer. One turns it on, one turns it off. And I need to call Derek in probably twice a day to ask him, do I push the top button or the bottom button? So Derek has the pressure of trying to make sure he's so kind to me by not telling me, okay, you're an idiot, push the bottom button. So I really thank Derek a lot. Steve,
That's our job, Robert.
You can't talk, Steve. You're muted. You're muted.
I think that's a matter of labels.
Derek is muting you, Steve. But I do want to thank David for the incredible report and the future and the way you have to look at it, because the future just passed us 10 seconds ago, and now we got the new future. So thank you. When Chuck Weber was the chairman of the surgery department, and when Chuck Weber was retired, and when Chuck Weber became a member of this board, the foundation by which Chuck Weber and all of you have is quality. We can't do anything around here if we don't have the quality standards. If you don't have quality, you don't have proper clinics. If you don't have quality, you don't have proper surgery. So we wanted Dr. Stevenson to come in and give you an idea of the quality efforts, because it really truly supersedes anything and everything that we do. So Rob, if you would begin your presentation, I would certainly appreciate it. And we have Rob in the OPC so that he doesn't sound like Mickey Mouse anymore.
Actually, I'm in my office.
Oh, there you go.
But I think that hopefully I won't sound like Mickey Mouse this time. Jeffrey, could we move forward to my slide deck, please? There we go. Actually, we'll start with the title slide for a second. Before we get into the accomplishments, I think it's important to talk about what the quality division is, because it's not exactly the same in every organization. And so at JPS, what the quality division is really, in a way, we're sort of like the brain trust of providing that guidance, support, consultative ideas, teaching, education to help our organization improve. That's really what we're about, and improving in patient care, improving in safety of the environment, improving in our regulatory compliance and readiness, improving in how many infections we have, all that stuff. So we are, so we need to be a group that is dedicated to learning, to growing, and to helping the organization learn and grow as well. So our 2020, and the other thing I should say is that we've really been in the middle of the COVID-19 business in a big way in the quality division. Obviously, there's been a lot to understand about this disease, which our infection prevention team has been hugely instrumental in assisting us with. My executive director, Allison Windus, is literally the owner of the PPE grid. So when the question is, what PPE do I need to wear where, she's the person who has that information for the organization. And then I've been very fortunate to lead an incredibly dynamic group of clinical leaders, both operational leaders as well as physicians in the clinical steering team, to understand really everything about the pandemic and trying to interpret that information to guide us in really all of our decision making, whether it's a response to an issue in behavioral health that helped to stand up the COVID unit that you learned about over there, or whether it's standing up our COVID ICU, or whether it's interpreting PPE guidelines or return to work guidelines for employees, or all those sorts of things. Those decisions have been aided for the organization by the work of this clinical steering team, and an incredibly dynamic group that I've been privileged to lead with Dr. Steve Davis, our chief of medicine. So as far as our 2020 accomplishments, it's been quite a year. Probably the overarching most important thing that we've accomplished is really stabilizing the quality division. We had a lot of turnover when I came on board, and there was also a lot of little silos in the group that we had to break through and get them collaborating and learning together. And that's been unbelievably successful. And the goal here really is to develop that learning culture in the quality division so that we can model it for the whole organization. Because organizations that improve, if you look at the characteristics of those organizations that are on a course of improvement, it's that there's a learning culture that pervades everything that's happening in that organization. So it was our goal to model that, and we're seeing that really come about in leaps and bounds within the quality division, and it's really spreading out across the organization as people engage with the process of improvement. We established in-house capabilities of environmental care and life safety, which has been hugely helpful in identifying opportunities to improve in terms of the safety of our environment. We have created a structure for continuous regulatory preparedness, and that in hand with the EOC life safety improvements really is about creating a place where, again, I think this goes back to some of the first comments I think I made to this board back in the early time of my tenure in this role, is about leveraging these things that people ask us to do to become that kind of organization that provides unbelievably safe care for our patients, and a safe place for us to work, and a safe place for visitors to come and visit their family members or us if they have to come see us. As far as specific achievements, at the end of fiscal 19, we did achieve goal in PSI 90, and currently we're performing at stretch. So this is this measure of patient safety events that we should try to avoid. And this is this risk-adjusted weighted measure of these, and currently we're performing significantly better than would be expected for the patients that we take care of, and that observed to expected ratio is currently 0.85, so that's a very good number for us. We have received national recognition for registry performance for stroke, cardiovascular, and orthopedics, so this is out of our outcomes management group, which along with managing the PSI 90 goal, also provides registry support to numerous disease-specific accreditations that we have, and so we have continued to perform at a very, very high level in these areas. And one of the things that should be noted is yesterday we completed our stroke survey and passed with flying colors. That's not only from us, that's a huge lift from providers, huge lift from nursing, but that continues to be an unbelievably strong program at JPS, which we in the quality division are proud to support. We have continued to have our employees actually report more and more events to us, which is great because they're letting us know what they're seeing and what they're hearing. But at the same time, even though the total number of events reported has gone up, our sentinel events, our most serious harm events, they've actually gone down by about 50% year to year, 19 to 20. And that's actually, that change is dramatic because we had been really about the same level of sentinel events for quite a long time. But our processes in terms of responding to sentinel events, making sure that we have robust action plans, that they're spread across the organization, and that there's real accountability to getting these things closed. I think that's really translated into a very different set of not only number of events, but also a very different quality of the sorts of events that we've been seeing. And actually, we've had, I think, 2 of the 5 events that have been reported in this fiscal year have had no action plans. We did everything we could have done. It's just one of those things that happened. We've improved performance in catheter-associated urinary tract infections, Clostridium difficile infections, and MRSA infections. So those are some of the serious infections that caused tremendous harm and suffering to our patients. We've dramatically improved performance in those areas, and we've maintained excellent performance in surgical site infections, as well as the catheter-associated central line-associated bloodstream infections. And then, as I mentioned, our infection prevention team was really, especially in the early days of COVID, where they're literally up day and night, working with public health, working with our colleagues in the emergency department across the organization to understand what to do in the response. And they provided a tremendous amount of subject matter expertise to the organization. Next slide, please. Jeffrey, next slide, please. Thank you. So why is this all so important, and especially why is it so important in budget season? Obviously, to improve, to become safer, to become a place where harm is rare, where it's troublesome when it occurs, it bothers us when it occurs. It's not one of those things you go back. I started my life in healthcare, and Dr. Weber will certainly recall these days, but you go back to the 80s and 90s, and you sort of figured, stuff happens. I mean, bad things happen when people are sick. Nowadays, we know that this kind of harm is almost always avoidable, and it should bother us when it occurs. But from a financial standpoint, it also is bothersome. Every time we have a serious safety event, this is national data, there's an added cost to that individual's care of almost $60,000. And, you know, and I think it's worth, of course, celebrating the fact that Washington Monthly thought we were the best, or rated us as the best hospital in the country. And, you know, and there was a lot of incredibly good news in that story, but but you know, we're JPS and we always want to improve. And so you dig into the data and you see, yeah, there's still some opportunities for improvement there. And if you compare us across the country in terms of patient safety, we're not even at the 60th percentile. So we do have room to improve and grow. And it is absolutely the goal of our quality division, and really in collaboration with all the groups across the hospital, to see that number be every bit as high as our numbers for community engagement, which, you know, we're really off the charts, or our rating for not providing unnecessary care and treatment. So what's at the root of some of the challenges for improving safety across the country? And so one of those big things is that there's still cultural issues in healthcare that need to be improved. And one of them is that if you look across the country, about 50% of healthcare workers fear that there will be retribution if they either commit or report an error. And JPS kind of tracks right in there. So we still have some areas to improve there. And it's of note that nobody's actually very good at this, because the very best places in the country, it's 40% of the healthcare workers fear retribution. So it's a narrow grouping there in the middle, and we still have a long way to go with that, but we can definitely improve those cultural issues. And it's one of the big goals that we have for the future. In addition to the serious safety events, the infections I mentioned add a lot to the cost of patients' care, in addition to, of course, causing tremendous suffering for them. And this is, of course, the main reason that we want to try to improve. But then on top of all of that, and in addition to those costs that we experience directly to our bottom line, with value-based purchasing, you know, we stand to be penalized if we don't actually improve our performance. And that number is due to grow every year. And they're projecting for fiscal year 2021 that it could be as high as $1.26 million. Next slide, please. So to address all of this, really where we need to go is to get on a journey towards high reliability for JPS Health Network. And a cornerstone of that is to establish and maintain a robust safety culture. And the safety culture really gives people the confidence to be transparent, to raise their hands, to say, I see things that are going on. I need to let people know that there's an area here that we need to improve. And so that's going to be a huge goal for us in the coming years. And you know, it's a journey that won't happen overnight, because cultural change takes time, but it's somewhere that we absolutely have to go. And, you know, as the #1 hospital in the country, we need to lead the way in this, really. In terms of specific objectives, we certainly want to see improvements in leapfrog grade and CMS star. I think a lot of the work that we've been doing in PSI 90 should contribute to that, as well as the hard work that we've been doing in infection prevention. And specific to that, we obviously want to be well better than expected in all of our hospital-acquired infections. And we're very close to being there. We still have a little bit of work to do in surgical site infection. But overall, we are now performing in a very good range and really across the board in all the hospital-acquired infections. The key to this is hand hygiene. I will thank COVID for improving our hand hygiene rates a little bit more. We were performing around 90%. Now we're across the board above 95%, which is, you know, given everybody's concerns about COVID, are not surprising, but obviously we'll need to keep our eyes on that if we ever start drifting out of this COVID business, and make sure that people are remaining vigilant on this. It is absolutely the #1 thing that we need to do to prevent hospital-acquired infections across the board. And we've reinvigorated our antimicrobial stewardship program. We never really got out of, so antimicrobial stewardship means making sure that we use the right antibiotics for the right indications and don't overtreat. And so on the outpatient side, we've actually been very strong in this area. On the inpatient side, actually, we've also been strong really for the last 3 or 4 years, but I did sense over the course of the last 12 months some weakening in this area. So we've and there was some evidence to believe that as well. And so we have reinvigorated this effort. And I, literally over the last week, I've sort of let people know what we've been seeing. And you know, we have such an engaged group of physician leaders. They've all jumped over it and jumped all over it and are re-engaging in a big way. And so I'm expecting some really great work to be done in this area, even over the next few weeks and months. Obviously, we want to go from simply getting ready for the next survey to always being ready. And the reason we always want to be ready is because a place that's always ready is a really, really safe place to receive care. Because what those regulations are really saying is, these are the best practices. These are the things you need to do to be a safe place to deliver healthcare. So when you're always ready, you're always safe. So that is a very, very important principle. And we have already established that structure, and now it's about getting us absolutely ready for this next survey, which should be coming sometime in the early part of calendar year 21, and then just keeping the eye on the ball all the time. And then finally, we do want to make sure that we have a robust clinical risk management program. It's been a bit of a gap for us over the last few years, and so we're going to close that gap actually with a new manager of clinical risk and patient safety starting next month. But then we'll build out that team a little bit more as well, hopefully over the next period of time to make sure that we have a robust support in that area. So that's where we're going in quality. It's about continuous improvement. It's about an absolute dedication to safety. It's about collaboration. It's about cooperation. It's about learning. And so we're excited to be on the journey and excited to help JPS become that place where everybody, you know, can receive very safe, high quality care all the time. My mantra on quality is quality healthcare is the healthcare you'd want your family member to receive without any special arrangements needed. And it will always be our journey at JPS to go to that place and to attempt to get to that place. And, you know, it's probably probably technically unattainable, but it's always going to be our goal for our patients and for our community. And with that, I'll stop and I'll be glad to answer any questions.
Are there questions that y'all have of Rob?
I don't, but Rob, this is Steve. That's great. I in all my years at JPS, I've never been as encouraged as I am now about our trajectory on the quality front, and I attribute a lot of that to you, and I appreciate that. And a lot of what you're saying is, a lot of your initiatives are embedded in everything we do, but a lot of what it sounds like you're saying is, you know, these are expensive things to do sometimes, but they're more expensive not to do them. So thank you for what you're doing.
Thank you.
One of the things that Rob mentioned that I want to highlight a bit, and Rob, that was a very good report and greatly appreciative. There are things that happen at JPS every day, and some of them are incredibly impactful. There aren't a huge amount of certified stroke centers in the nation, and we're lucky enough to be one of them. We conducted a virtual survey yesterday. We had a lady from the Houston area, and we had a lady from Boston, Massachusetts, who came in and surveyed us. And their compliments of our stroke team and our stroke center was phenomenal. The lady who's the lead surveyor, and I mean no disrespect to surveyors, but they oftentimes have all their humor and personality stripped from them before they come into our building. They are tough. They are much like, an IRS officer that comes in to look at everything. And this lead surveyor was incredibly complimentary of our team and what we do, and was also exceptionally complimentary about our award and being one of the best hospitals. She had surveyed us before, and she said, I'm really excited that you all were recognized for that. She is a previous employee of Memorial Hermann, and Memorial Hermann finished in the top 20. And when we said we were number one, she made comment about Memorial Hermann being a great place, but they only made it to the top 20. So it was really a nice compliment to you as board members and us. And to that point, Wanda and Lori Spears and a huge amount of people that really make a lot of things happen for us really allowed for a one-day survey, which is not common either. It usually takes longer, but when they see good stuff, they move on. So I can't talk enough about what Rob mentioned. And Rob, thank you for mentioning that survey. And Wanda and Lori, they're superheroes to us, and they do really good stuff. So thanks, Rob. Appreciate the presentation. Any other questions that you all have? As we consider the future, one of the things that we have to consider is the training for those physicians. And if you all recall, in that award that we received, were the in the metrics that they put together with the Loan Group and the Loan Institute and Washington Monthly, we were #1 for teaching hospital in the United States. That did put us in with the category of Johns Hopkins and other teaching hospitals. You all as board members need to understand that. And when you have a person like Tricia Elliott, you can see why you are the #1 teaching hospital and what she is doing to put her effort into residency programs and research programs. I'm proud of Dr. Elliott. She's done a good job. So Dr. Elliott, could you please give us an update on your slides? She, by the way, just for full disclosure, was the one who is the most frustrated by the reduction of slides. She is putting on a face today, but she was livid for the last week. So just getting that out in the open.
Oh, thanks, Robert, for that introduction. I appreciate it very much. Can you guys hear me okay? Does everyone hear me okay?
Yes.
Oh, fantastic. Fantastic. Well, thank you so much for this opportunity. And yes, it was a bit of a struggle, but we got it down to 3 slides. So I'll definitely be able to walk you through those slides. Even if they appear a bit busy, we'll make sure I'm able to touch all the areas that need to be touched. So we're excited to be able to talk a little bit about what we do in medical staff, academic, and research affairs in regards to our division. Next slide. And of course, we're really excited about the #1 teaching hospital designation. I think of note to realize that we've been recognized above other organizations, as Robert mentioned, that have many, many more residents and residency programs than we have across different specialties. And the fact that with our wonderful group here of over 200 plus residents and over 10 residency programs here and fellowships, that we're able to be recognized as #1 is a true testament. So this is a collective effort across all of us here at JPS. And I always say that we are all teachers here. So thank you so much for that. I'll give a little bit of a rundown of our accomplishments here. I'm going to start with academic affairs. And so we continue to do well in our board pass rate for our graduating residents, continuing to maintain above 95%, which is always our goal there. And we had our recent board pass rate of 98%. And so we were excited to continue that and always continuing the efforts to support our programs to be able to accomplish that, because our ultimate goal is always to have board certified physicians who are representing us here from JPS across this county and the country. And then we're also really excited about the efforts, really with the help of not only the direction of our board here, but a lot of the wonderful effort we've done collaboratively with our physician group partners such as Acclaim and IAS and others to really look at how we can retain more of our residents as faculty. Over the past 3 years, we've retained about 24. We're maintaining about a 15% retention rate right now over the last 2 years. And I'm really excited about that. And we're going to continue that effort to even see that grow more. We've also actually even seen that we've had more residents stay within the Tarrant County area, even in this last 2 years too, which has been a great accomplishment there. We continue to be fully accredited for all of our residency and fellowship programs, even receiving commendation for our institutional accreditation and several of our residency programs. So we monitor that closely, working very closely with each program and our graduate medical education committee to keep that accreditation going with all of our agencies. Those agencies include the Accreditation Council for Graduate Medical Education and the Council for Podiatric Medicine Medical Education also. Our big news this year, definitely working with our finance team and with everybody across the board there, is that we were excited that the Texas Texas legislature, through the Texas Coordinating Board, put out another call for a grant for GME expansion. And so, of course, we jumped on that back in December, and we were pleased to be able to really align with the mission of our organization here in terms of our growth of GME. And we were able to secure $1.4 million of grant funding for emergency medicine, family medicine, and psychiatry here. And that has been a huge win. That allows us to expand our residency by 2 slots per year. And we anticipate that will be continued funding moving forward. So that's been a huge, huge win for us here. So we're pleased to always looking for those revenue dollars to support our GME funding here in collaboration with our finance group. Just wanted to also let you know that with academic affairs, well-being is a big part of that. You've heard about well-being across the needs for all of our clinicians, our physicians, our APPs, our nurses, everyone needing more in terms of focus on well-being. And so with that, the ACGMEs have really targeted and really made sure that residency programs and fellowships are really having their eye on well-being. With that, about 1.5 years ago, we actually developed a new position called the Director of Interprofessional Wellbeing, which I have Dr. Glenda Mutinda leading that as director. And she's worked very, very closely across the board with our patient experience team, our EAP team, our behavioral health team. And it's just wonderful now that we have this really strong care for the caregiver group. We've got actually 4 incredible directors that span from our spiritual and ethics director to our EAP director, to our behavioral health directors, and along with our director in ACGME, who really lead all of the efforts around our care for the caregiver team. And it's really not only about helping our residents and our faculty, but it's really about our entire caregiver team. So they do efforts across the board for all of our staff across the board. And so we're excited to be able to see that expanding. We've even done some things around expanding access to mental health services for residents utilizing technology. And that is something that actually got kind of launched a little bit ahead of time because of COVID, and it's been a real success to be able to see that happen. And so we're looking at opportunities of where that could go even in the future for the rest of our caregiver team across the network. I want to talk a little bit about research, so letting you know we're so active in research. We've got 2 areas of research we're always proud to be able to show, and that's our Office of Clinical Research headed by Dr. Melissa Acosta, and then our Center for Outcomes Research headed by Dr. Rohit Ojha. And I just wanted to mention Academic Affairs is headed by Diana Singer. So research, we continue to really work very, very closely across the organization to expand our research. It has grown significantly in the last 3.5 years, and we're so proud of that. A lot of wonderful local and regional and national collaborations that are happening. Just this past year, we've been awarded over $500,000 in grant funding along different areas of grants that you see listed there. We're doing research in multiple different areas across the organization, and including with the Center for Outcomes Research, focusing on areas such as HIV, substance abuse, and cancer. And that has been really instrumental in improving the outcomes for our patients, really helping our clinical processes. Our physicians love partnering with our research team because it really does improve the outcomes for our patients, and it's helping us move towards even better care and quality. Also, clinical trials. We've expanded and grown in our clinical trial areas, over $340,000 in clinical trial revenue continuing to come in. And this actually is growing significantly in the last 3 months due to COVID, actually. We've had a lot of COVID-related research activities happening now and growing. This includes not only clinical trials and emergency use protocols so that we can provide better care for our patients, our COVID patients. We've also part of national data registries where we're able to look at some of the demographics and epidemiology of our patients that are happening here. And I think some of you are even going to be seeing some of those areas of disparities and how we're able to do that. And that's our team working very closely across the network to help to do that. And we were excited to be able to have a successful research symposium this year, which had to go virtual. And I have to give kudos to the team because COVID pushed us to have to go virtual, and they were able to turn around a virtual research symposium in all just about 1 month period, which was really remarkable to see that. And actually with that virtual platform, we were able to see a 50% increase in attendance, and then research submissions went up significantly. So we had quite a bit, and we're excited to be able to even look at the future to say, how can we actually do a hybrid of in-person and virtual in the future? And then I just wanted to point out, the research that we do does translate into cost savings. And so we are looking at things, for instance, in the substance abuse hepatitis C testing area. Our research has even identified opportunities for cost savings where some upwards of $500,000 could be eliminated. So those are things they're working on clinically and also going to be working on with our revenue departments to be able to look at opportunities for that. Wanted to tell you a little bit about medical staff. So I've been working with medical staff over the last year or so, and it's been a really exciting journey. Our biggest thing here is we're excited that we were able to successfully recruit an executive director, Cindy Radcliffe. Cindy has over 20 years experience. Has really come in the last 9 months and really hit the ground running. And she's developed new processes and conducting gap analyses where she's able to kind of see where our needs are. So really kind of creating a process looking ahead. She's already done things around new department chair orientations and looking at packets of how we can engage our chairs and our physicians, even more so through the credentialing process. And then also looking at our peer review process, looking for opportunities there to be able to improve that and continue that. And also looking at our regulatory needs around Joint Commission. As you heard, we had a successful stroke survey yesterday, and our team is also a part of that. And so I was really pleased for them to be a part of that, and it's really a collective effort. So more to come on medical staff, but that's where we are, and I'm looking forward to the road ahead with that. Let's go to the next slide. Next slide. So this is a slide from the Association of American Medical Colleges. This is where we're also a part of that, the Council of Teaching Hospitals with the AAMC. And this is just kind of highlighting to you why we do what we do, because we are definitely, as a teaching hospital, the future of healthcare. It's truly about providing comprehensive medical education and training for our students and our residents. And as you know, we not only do our residents, but we do our students, and we really have that whole continuum there that we're able to create that pipeline. So we're here to educate and train tomorrow's doctors because we need that workforce. Because as you know, we're in a workforce shortage, not only here in Tarrant County and in Texas, but across the nation. And so being in the business of training doctors is critical because we need them to take care of not only me and us, we've got to take care of our future and take care of our current patients. I will tell you, our 200 plus residents and fellows are critical right now in the face of what we're doing now. They are our front line. And I just want to recognize them for the incredible work they're doing alongside our faculty, nurses, and our APPs, because we couldn't do the care we're doing in COVID, even right now, without our residents. They are manning it right there alongside with everyone. And so they're critical to the function. So that's why we do what we do. You'll see there 93% of residency programs train residents in non-hospital settings. They train in community health centers, private physician offices, VAs, ambulatory services, and ambulatory surgical centers. That's us. We do everything. So the fact that we're able to provide that comprehensive experience for them across different settings is critical. Then they're also important. Why do we do research? Because 50% of research occurs in teaching hospitals or medical schools. So it's important for us to be able to move that so we're improving the health outcomes for our patient and that we can pioneer those cures for our patients too. Also, oftentimes this is overlooked, is that actually 5% of all U.S. hospitals are teaching hospitals. However, we provide the majority of the clinical care and also the underserved care for our patients. So what we do counts. It's critical that we train our residents to be able to do this and that we are a teaching hospital providing this. And we stay oftentimes ahead of the curve in providing critical services that are not often provided elsewhere. Things such as comprehensive cancer care. The fact that 79% of all accredited level 1 trauma centers are part of a teaching hospital. So I just hope this highlights to you why we're doing what we're doing, and along with so much more. Let's go to the next slide. So I wanted to just say that we really just so grateful to the board for giving us a lot of direction. And we as a division always look at how we aligned with our organizational needs and strategies and the direction that you provide us. And so we sat together as a group, and we've really come together to really make sure that we have a strategic plan and a priority moving forward around these key areas. So our key areas that we focus are 5 key areas. We look at academic excellence, we look at clinical excellence, we look at workforce recruitment and retention, we look at what we're doing in research and innovation, and then we also look at how we're professionally developing our leaders of the future and currently. And so as you look at our academic excellence, we focus that why we're doing the things around GME, making sure that we're staying not only compliant around all of our crediting needs, but how are we growing in our GME areas? And then how are we actually really developing our pipeline of students and working locally, not just with our medical schools and our health science schools, but also wanting to be able to look at opportunities to look at our secondary schools. And so how are we going to look at some opportunities to create some pipelines for that and create academic excellence in a longitudinal manner? And then of course, our continuing education CME is part of what we do. We need to create lifelong learning. It's a critical component of medical education. And so we're excited to be able to partner with that, with our Health Science Center around that. And then, of course, really looking at the idea of well-being and the structure that we create around those partnerships of well-being. Clinical excellence, I want to kind of just tag into what Rob said. It's so critical what we do in terms of providing quality care and really achieving the quadruple aim that we want to achieve. And what we do every day in medical education and research contributes to that. The ACGME has what's called a clinical learning environment review, and patient safety, quality are critical components of that. So the work that we do with our quality team members and everyone across the board is critical. But you'll see that it also includes areas now such as teaming. How are we working within our interprofessional team? How are we communicating and collaborating in the clinical learning environment around teaming? So we're doing a lot of efforts around that. Supervision, well-being, and professionalism. And I will tell you, the CLEAR has become such a significant focus now that we have key team members that are helping us move that and working very closely with our teams across the network to make sure that we anticipate our next CLEAR visit anytime. Now they're on hold right now. We're in the window, but as soon as they break that window, we'll be back in that CLEAR window to be able to have a site visit here again. So we want to be prepared and ready, as Rob said, continual readiness around these areas. And then, of course, I want to talk about workforce recruitment and retention just briefly, is that we're always looking at opportunities of developing and implementing targeted recruitment strategies, because we want to retain our folks here too, but we want to bring folks into Tarrant County through students' education and through graduate medical education, and look at ways to really enhance our workforce needs here in JPS and Tarrant County. And so we look at things also around working with our physician partners, as I said, to be able to retain that clinical talent that we're training. But we also are looking at those things around diversity, equity, and inclusion. And it's very important that we have that workforce that is diverse. And so we've heard you guys, and I definitely am passionate about this too, especially looking at underrepresented in medicine and those particular minority groups, to see how we can enhance that here. So last year we started with the GMEC, just starting that conversation of a longitudinal several year plan, because it's going to take a while to move that needle to be able to enhance and improve our diversity in our graduate medical education. So in collaboration with our Chief Diversity Officer, Michelle Green-Ford, we are doing this effort, and our program directors are taking it upon themselves to really say, how can I look at this more closely in our recruitment efforts to enhance our diversity and inclusion? So we have a strategy that we're doing around that too. That's a long-term strategy. And then just going to research and innovation, just talking a little bit more about enhancing our scholarship, our scholarly activities, and really making sure that we're building the infrastructure to enhance our collaborations, not only locally and regionally, but nationally too, because we've got to set that infrastructure and foundation, and we need those collaborations to be able to bring that wonderful research and innovation here to us at JPS. And then last but not least, just we always are looking at how we do leadership development, because we are training the future leaders of healthcare. So how do we engage them in the activities that we're doing here and give them the skills and attitudes and knowledge that they need to be future healthcare leaders? And so we do a lot of things around leadership development here too that we're actively engaged in. So I just wanted to give you just a little bit of an overview just to show that we are looking ahead, and we so welcome your input and your questions, and so grateful for your support and continued support of what we do here in our medical staff, academic, and research affairs area here at JPS. And we're proud to be a part of this. So thank you.
Thank you, Dr. Elliott. I'm sorry, Robert?
No, I'm sorry, Steve. Do any of y'all have questions for Dr. Elliott? Tricia, thank you. Yeah, I'm sorry, Pastor Emerson.
Dr. Elliott, have y'all started to do any work coordination with HBCUs?
Yeah, so actually, Dr. Emerson, Reverend Emerson, yes, we have actually. Part of our diversity and inclusion initiatives that we just instituted just several months ago at the early part of last academic year was to look at ways around recruiting strategies. And so what we've done actually is look at contacting some of the HBCUs. We've also looked at how we could do some recruiting fairs to be able to look. The Student National Medical Association is a student organization of the National Medical Association. And just to let everybody know, the National Medical Association was formed many years ago when Black physicians were not allowed to be a part of the AMA. And so it's been a historical organization that has done a lot of great work around advancing the needs for Black physicians across the country. And so the Student National Medical Association, they have regional components and they have national components. So we have actually invested in going. We've done recruitment fairs at our regional one. That there was one that was held in November actually in Dallas. That was for the whole region, Texas and beyond, and Louisiana region. So we have done some fairs there where we send residents and my staff. We were supposed to be a part of the Student National Medical Association National Fair in April, but of course COVID put something on that, delayed that. We also looking at our LMSA, it's the Latino Medical Student Association. So we're looking at things that are specifically looking at targeting some of our URM areas. And so HBCUs, we actually had some of our own residents who were actually graduates, a couple graduates of Howard University, went up to Howard University and did a nice fair up there to be able to introduce them to JPS. Because one of the things we've realized and we've heard from our residents and our students is that they want to know about it. They don't get to know about JPS and some of these HBCUs and even across some of the areas, other colleges across the country. So we just have early efforts there, but you hit the nail on the head, Reverend Emerson. That's part of our areas is looking at how do we partner with HBCUs. And then I would also say I'd like to also we're looking at ways to partner with local high schools that may be affected in areas that have more underrepresented minorities in their student population too. So we're looking for opportunities. We're very early in the phase, and that's why I think our diversity and inclusion initiative, we realize is going to take several years, but we need the help to be able to do it, move it forward.
Great. Hey, Dr. Elliott, I had a question about international students, and especially I know we had spoken briefly about the challenges that you're going to be facing this year, especially as I know your residency program is supposed to start very soon, if it hadn't already started, and what that looked like for the remainder of this year next.
Sure. So I think your point with Amanda, yes, we have started. Our academic year goes from July 1st to June 30th. So we definitely have new interns, new physicians who are here, hit the ground running already and working very closely. They've been with us for a month now, 2 weeks of orientation, and already working 2 weeks into their clinical rotations. With regards to the international piece, there's been a lot of discussion nationally looking at that, where our immigration policies and where these things can potentially impact the ability to have international medical graduates as part of our programs. We historically don't have a lot of international medical graduates in our program because we're so competitive. And right now, actually, we've got the growth in American medical graduates that has happened significantly in the last few years. Unfortunately, there's not as many residency slots as we have students who are graduating. So that has been a challenge. So the flip side of that is that we have a lot more American students who are applying to us now, but we still interview, and we have our international students too. The challenge is that I think it's just the number of slots that we have. We've had international students, as I've mentioned in the past, but this year we haven't had anyone. And if there are any international students, they don't have any kind of visa status issues at all at this time. So we're actually in a good place. But when we do look at any of that, we go through what's called the ECFMG. And they help us, and that's where we usually do our work with around visa issues around that. But right now we're in a good place where we don't have any issues, but we're always looking at opportunities to improve.
Great, thank you.
Anytime. Thanks. Thank you, Amanda.
For Dr. Elliott, I'm seeing in the chat room a huge amount of questions about why is there such a glow about Trisha Elliott.
I don't see that chat.
Yeah, there's a chat. I see 11 comments in the chat room. Since the last time Dr. Elliott presented to you all, she's gotten married. So the glow that you see on Dr. Elliott's face is marriage. So
Hey.
Dr. Elliott, thank you very much. And I will certainly expect for my comments regarding you, both at the introduction and the conclusion, to have a price that I must pay. But thank you very much.
I'll point out, Robert, she did have just 3 slides, but there was a lot of information on each one of those.
Yes, it's the academician in me. It's the academician in me. Yes.
I wish you could have been here to see the conversation between Trish Elliott and Sharon Clark about the slides and the amount of information.
It's an 8-point font.
Maybe we can institute a minimum font size rule for the next one.
Well,
no problem.
The discussion that Sharon and Trisha had, we were thinking of using that as a fundraiser and selling tickets to it. We decided no, probably not a good idea. It would make our foundation too large.
Hey.
No, we don't do that.
Hey, Sharon and I are always good. We're always good.
That was not a true comment, Robert.
Thank you guys very, very much. Dr. Elliott, thank you. And excellent.
You're welcome.
We are down to our last presenter. And what we thought we would do is give you guys a summation based on none of these things can happen unless you have 7,200 or at least whatever we have right now, workforce of stellar people doing great work. So Alex Dubuclet is going to give us a bit of an idea of where we stand with our efforts. And I will compliment Alex by telling you that he has jumped into his role as interim in a major way. To be able to put a presentation like this together and know it backwards and forwards in the short time that he's been there is impressive. So Alex, we are grateful for the presentation. If you would like to give your presentation to the board members and Dr. Weber's dogs, we are ready for you to do so.
Thank you, Mr. Early. Chairman Weber and your dogs, member of the Board of Managers, Alex Dubuclet. Nice to be here. Thank you for having me. I want to start with accomplishments for the Human Resources team. Obviously, I've only been here 6 weeks, so I'm not going to take credit for any of these accomplishments, but I'm certainly helping out as I am often ready to do. First thing I want to talk about is that when I arrived here, you were in the thick of COVID, and at the time, most of the screeners who you see at the doors and entryways across the organization were people who actually had other jobs here at JPS, and they were nurses, there were pharmacy techs, there were just different people across the board who were at these doors at the ready, ensuring the safety of our patients and of our employees. And what that told me when I walked through the door was that this is a place where people just jump in. And this is a place when you ask them to do something that's outside of their normal job, they say, what time should I show up? And they show up. So it was just another reminder of the great culture that exists at JPS. But speaking of screeners, now that we are seeing more and more of COVID and we don't know when it's going to go away, we made a decision. And that decision was to hire a good number of screeners and create this as a full-time job, at least while we still have COVID around. And so we went from having 0 screeners, not having that position title at all within the organization, to hiring over 65, and we'll likely hire a few more. One positive out of this is that it has provided additional employment opportunities from some of the very communities where our patients come from and the patients that we serve in those communities. And so I see that as always a positive when we can employ people from the communities that surround and that are in our service area. HRIS, tuition management system, very briefly share with you that they've just made it a whole lot easier for the employees who take advantage of the tuition reimbursement benefit here to track who's taking, who's receiving the benefits for tuition assistance program, for the reporting that shows up in their pay stubs to let them know. And I'm going to talk a little bit more about that later, but it was definitely a strong advance in terms of ease of management of that program. And lastly, provider applicant tracking. This was a project where they partnered with, HR partnered with a claim, and it really was to create just an applicant tracking system, an interface where it helped them, quite frankly, modernize their recruitment process and automate it. So they were really tracking this data using Excel spreadsheets. And someone with a talent acquisition background like myself, I will tell you, tracking any recruitment process via spreadsheet is a nightmare. And so that nightmare no longer exists. So that was a real big plus last year. This year that was accomplished. Lastly, let's talk about some diversity inclusion accomplishments and what we've been doing recently in this space. And this is something that I was here to see and see launch. Mr. Early, and you can go to the next slide too, Jeffrey, please. I'm sorry. Mr. Early and Dr. Duncan really wanted to have a strong response for the employees and a supportive response as it relates to the George Floyd killing and some of the racial injustice protests that were not only gripping our community, but the country. And Mr. Early had already reached out to the employee base several times and in a very passionate and supportive way. And they made it clear to our team that they wanted to continue the healing and continue the education around what the response has been in the community, and to make sure that people understood that people process these events in very different ways. And these guided discussions that were implemented just about 2 weeks ago are ongoing, and they're for all of the leaders across the organization. And it's really giving them an opportunity to share, learn from one another, express themselves. Some folks have even admitted to crying on these guided discussions because it's been that impactful. Of course, that wasn't me, or maybe it was, but the other projects we've been working on in D&I are Serving with Sensitivity. And that has been a launch of several different programs. Some have been around cultural competent care, cross-cultural communication, homelessness awareness, patient culture and end-of-life care. So lots of different topics where we've had great numbers of employees participate in these sessions. And there are more to come in the near future. Some on mental health and cultural diversity and patients' perspective on homelessness. So some really good, strong topics to share with team members, and it really helps in how we actually care for patients to ensure that people have a sensitivity around some of these issues. The next slide, please, Jeffrey. Thank you. I want to give you just some key stats really quickly. I think Mr. Early said it all when he opened this section, and that was, he said, all these wonderful accomplishments that my teammates have spoken to you about today could not be accomplished without the team members that make up this great organization. And I just want to point out that there's been some significant growth over the past 3 years of the total team members, especially with a lot of that growth coming from the claim side of the business. From 20 to 2018, Acclaim saw slightly over 15% growth in their employee population, and JPS employees grew slightly over 6% over that same time period. And then as you look at the slide on the right, it's just simply letting you know that our physicians, 65% of our physicians are employees, about 35% are contractors. And that's an important stat. As you might recall, David, who gave a great presentation on technology and even referenced what the state of the workforce might look like in the future, really talked about the gig economy, et cetera. Well, this is really forward thinking on JPS's side, coming in here for a fresh set of eyes. From my perspective, I look at that split and I say, wow, that's good stuff, because the future is really about mixing permanent employees with a sort of an ecosystem of sort of fluid talent, right? Independent contractors, consultants, contingent workers, part-time, and that ecosystem will merge with that permanent employee group and really make really is a snapshot of the new world workforce, in my opinion. And I think that ends. Yes.
Alex?
Yes.
I thought that we have the number on their show a different number than what I'm used to. I thought we have 6,500. Is there?
Oh, sure. Yeah. Good question. Yes. So I look at team members across the total of the organization, the whole of the organization. So not only JPS Health, but also Acclaim. And so when you add all of those together, they're different company numbers, but when you look at the total team members, that's how you arrive at that number.
And DT, I believe this is Sharon. I believe that 6,500 number was about 2 years old as well.
Yeah. It's more now, I think, Sharon, about 7,200 or so.
Oh, I see. So that would include all the part-time PRN and everything else that we receive.
That's right.
Okay, got it. Thanks.
Yeah, you're welcome. Thank you.
Do you all have any other questions of Alex or anything related to human resources? Well, Alex, thank you very much.
Thank you.
Thank you, Alex.
Thank you.
Your time here. I thought what I would do, Mr. Chairman Montgomery, if you don't mind, I'll make a few comments and then I'll turn it over to you and you can close out the meeting. I know that we've got just a few other deals, but if that suits you, that's what we can do.
Yeah, sounds good.
A couple of comments. I had literally 2 seconds before this meeting started to talk to Chairwoman DeBose from the Human Resources side and her role as chair of Acclaim. We did not discuss Acclaim today because that would have obviously extended our time, and we really think that that's worthy of its own discussion. So what our plans are is to meet with Mr. Montgomery as chair of finance, meet with Ms. DeBose, and meet with Dr. Weber. Ms. DeBose mentioned that could be done at the executive committee of Acclaim, or we could do that individually. But we will do a deep dive into Acclaim and then bring that information back to you as board members. Didn't want you to think for any reason that that is not part of our discussions and part of our situation. Acclaim, probably more than anywhere else because of the physicians that are part of that, has been affected by COVID-19 more than anything else financially, with the declines in patients and the shifting and changes that has had significant impact. And we need to review that impact and figure out where we go in the future. The other thing that I think is going to be weighty on you as board members is the 3 areas of correctional health, public health, and MHMR. You heard earlier some comments about public health and the role that JPS should or should not or could play in trying to help our community and working with our county commissioners and our judge. That also goes and holds true for correctional health. We want to do right by the county. We want to do right by those who are waiting trials that sit in our county jails and make sure that they have the proper health. At the same time, we have to be realistic with the ever increasing numbers of the inmates that are coming into our correctional health facility at the county level, particularly with changes being made by magistrate orders on city jails and those that are now seen at correctional health facilities that are owned by the county, which we provide correctional health for. So we need to have a very open and clear discussion about not only those costs, but the care and what impact it has on our nursing staff and our hospital staff. And then what we do and how we help MHMR and what the overall plan is for our county and those in need of behavioral and psychiatric health, and those who don't hit the doors at JPS but might hit the doors of our jail. And you all know that the single worst place probably for behavioral health is just putting somebody in a jail type setting. They have to, through either MHMR or any help that JPS could provide, or looking at diversion type programs, we need to look at that. So that will be weighty on the overall budget. And then the discussions that we've had ongoing regarding population health and what we do when you start looking at caseworkers and reaching people in their homes, and the pilot program we were just about to do before COVID-19 that we've suspended on 3 meals a day for a period of time going to our diabetic patients and doing a pilot program. All of those things, I think, are going to be weighty potential issues as we head into the next budget session. So, Mr. Chair, those are the comments that I have, and you certainly, your committee and whatever you want to do to close us out, feel free.
Steve, this is Dorothy. Before we close out,
yes, ma'am.
When we're talking about the public health, now you know they went before the county commissioners and wanted to hire a lot more trackers for this COVID. So I know that's going to be coming to us. So we need to be prepared for that and how we can work with them on that. That might lead them into looking at the clinical that we wanted to oversee versus the other stuff. Okay, I know
Good
that's
point.
coming.
I think you're right. I think we can count on it coming.
Mm-hmm.
So thanks for raising that. So I would,
Steve.
Yes, sir.
Just Reverend Emerson, I don't know if this is the form to raise this, or is it something that goes for the board? But when you get into the discussion with the physicians group and a claim, it would be good to know where we are now as we going into budget. Are we where we wanted to be with a claim at this point? Our vision for developing that physicians group. We went through some storms early on, forming the UNT and not UNT, and it'd be good to know where we are now. I mean, do we feel it was our best move?
I think that's a super valid question, Reverend Emerson. And I'm not sure the format either. I'll defer to the chairman and to Robert, but I think before we do the final budget, those are the kinds of questions we need to talk. We need to ask and talk about and have answered, because I think there are lots of questions from several of us about a claim, about its success, about trajectory and what we anticipate. Just a bunch of questions that I think we could spend a whole lot of time on, and we should spend a whole lot of time on. So I think before we approve the budget, those are the kind of questions we need to have answered. I would agree.
And I think the meeting that Robert spoke about maybe should be opened up to a few more of the board members so that those questions can be answered, and just set up a meeting for that, and we just talk about that.
I think that's perfect. Yeah, I agree.
All right.
Yeah, we have no concerns, and Reverend Emerson, to your point, what has developed over the years with a claim is truly a physician group that is a significant part of JPS. We don't have those issues with good, bad, or indifferent with UNT. They got out of that business. They don't run clinics for the most part. So over the years, our physician group has developed. The question is where are we going in the future? How do we deal with cost factors? How do we deal with attempting to reduce the losses, increase care for our patients, and shift to performance-based and removing ourselves from the episodic care that has us in a tight grip? And I think if you start looking at what we talked about the other day of dealing with our overall population health and how you manage our connection population and the role a claim plays in turning points. But the good thing now is have a good group of doctors wanting to move in the same direction. The divisiveness is no longer a part of it. I think they need a vision and a direction and guidance, but the divisiveness is no longer there, which is hugely helpful as we move forward.
Yeah.
May I make a suggestion? I don't know. There's no way we can do this in time, so the budget will stand on its own. But we need to start looking at value-based, population health value-based, purchasing value-based care type thing, so that we can realign physician compensation correctly. Otherwise, we're going to be misaligned very quickly. And that will be a very different event that we're going to have to talk about down the road.
Well, you're right, DT. And that was one of the things that Michael and I had talked about, that they were going to come back and discuss it. It's the perfect timing because they know we've got to do some things different. And so I think we can cover that as a part of that that meeting. Okay.
Good. I'm very encouraged with the infrastructure that the team has been discussing about, reaching out to patients, doing all those quality measures and everything else. I think it's just a matter of calibration on the other side, and we'll transform it nicely in the next few years.
Right. Thank you, D.
Great job.
Thank you.
Well, thank you all very much. Yes, sir.
I just think I couldn't let the meeting end without saying you did a great job organizing and pulling all of this together.
Amen. I'd love to take credit for it, and so I will. No, I'm kidding. I just want to thank all my colleagues. I truly treasure you all, and I'm so grateful for the opportunity to serve with you. I think we're all aligned in our passion for the organization, and I really enjoy all our moments together, even the long meetings like this. I appreciate you guys hanging in there on this. What I would ask is, if y'all think about over the next week, between now and next meeting, things that worked and didn't work, or things you'd like to add, or any kind of feedback you got, certainly direct it to me or Robert or Sharon or whomever you feel comfortable with. But I just want to make sure this works for all of us, and that we are able to weigh in and give that feedback back to the administration. And so then when we get to August 13th, we can really dive in on the numbers and really, get to the meat of the action. But I think this is a good prelude to that meeting. So thank you all very much. Thank you to the staff for an incredible amount of work. It's been inspiring to listen to you guys.
Amen. Good one, Steve.
Chairman, we appreciate you as board members, and we'll look forward to our continued meetings. You all go and have a good rest of the evening and have a good weekend. And Charlie, I know you had Jimmy John's for lunch. I'm sure you'll be having it for dinner. So
yeah, I've got the other half of the sandwich still here, Robert. Thank you.
Very good. Very good.
Hey, by the way, great meeting, and congratulations to staff, Robert, to you and the staff.
Great job. Thank you. Thank you.
Good job, everybody. Thanks.
Thank you.
Thanks.
Great job. Have a good weekend.
Good.